Hey guys, good morning. Am I audible? Am I visible? Hello, hi. A very good morning, Subhajit. Very good morning, everyone. Hope you are preparing for your INICET properly. It's going good and amazing preparation. Hopefully, you'll get your seat of choice. So, we'll start the INICET Marathon. So, I'm Dr. Ranjith. I'll be taking care of pathology, and you have an entire list of all the 19 subjects. The last few things, what you have to remember, read with respect to the PYQs and PYTs. That's what we're going to discuss. Here, it's more of a quick revision, very less conceptual understanding we'll have. We have that in our regular sessions, and I hope you have already done that part, right? Good morning, Gaurav. Good morning, Palash. Good morning, everyone. And we'll quickly go through what is required. See, first of all, even before going into the session, I want you to tell that INICET is a little bit different from your NEET PG. INICET has more weightage in the first and second year compared to NEET PG, right? So it's predominantly 60% of the questions comes from the basic sciences, and obviously 40% of the questions will be the integrated part and your clinical medicine, right? So, with respect to pathology, there are few areas which INICET more ask question compared to your NEET PG. One of them is your techniques, like the basics of pap smear, the fixation, the artifacts, right? All those things are a little bit more common in INICET, the hardcore pathology, and obviously you have a little bit of inclination towards hematology, especially if AIMS is going to take care of that, right? Yes, obviously, Vijit. Right, and if hematology also, it has more weightage on RBC, WBC disorders. Sometimes, rarely, you have huge amount of chunk of questions from blood transfusion medicine also, right? And the systemic pathology questions predominantly will be integrated, right? It will be integrated with your other subjects where you can have an input or understanding from the clinical question or from the microscopic aspect of it or from the blood test aspect of it, right? Good evening, Swati. Good morning, Swati. Fine. So that note, let's start. Quickly, let's go through. I want you guys to be more interactive. I'll ask you questions in between. I want you guys to answer, and obviously the PDF will be there with you in the Telegram group, right? Let's start. So first thing, like I said, I'm going to go for the unconventional things which we generally start with general pathology, right? So here I'm starting with instruments, what I want you to know, a little bit procedures which is there routinely done, and few fixators and others, right? So this is pap smear. Everyone knows that PAP is a type of an exfoliation cytology, right? So PAP is a cytological technique where I look at the cells, it automatically sheds. So we call it an exfoliation cytology, okay? We are not going to actively poke any tissue to get the cells. It's already exfoliated. We are looking at that, right? One more example for exfoliation cytology, which keeps on coming frequently in your INICET is zinc smear and the cells, right? Zinc smear is something which we use in a oral cavity for herpes. You have the multinucleation and everything. That's very commonly done. It's also a type of an exfoliation cytology, right? PAP has multiple things. This is the age-old person, the IR spatula. Right? The wooden stick looks like an ice cream stick. You have a little bit of a prolonged protruding edge and a common one, right? So what they do is, if this is cervical orifice, fine. So the pap smear is going to be like this. The IR spatula, and there'll be a 360-degree spin. The 360-degree spin will take the cervical mucus, and whatever cells are then the shed cervical mucus, we'll be looking into it, right? There are two types of pap smear. One is called as a conventional pap smear, which is done using oil spatula. You make a slide, you make a smear out of the mucus, whatever is getting, right? That's the conventional pap smear, right? And one more thing, this came once in an INICET exam called as LBC. LBC stands for liquid-based preparation. Here I don't take the mucus as such. I'm going to put into a liquid, centrifuge the liquid, and take a preparation, right? So the easiest way, if an image is given, how do I know it's an LBC? How do I know it's conventional? LBC will always be a circular thing. It will be a circle, and inside the circle there'll be cells, because that's where the centrifugation happens and the cells settle, right? And these two are the LBC preparating method, right? We have cyto brush, we have a cervical brush, right? So cervical broom is there, cervical brush is there, lots of variants are there. Again, the same concept is same. The entire instrument goes into the endocervical canal. They'll rotate it 360 degree, take the mucus, and what happens here is this part will be broken, this part will be broken and put into a liquid. It'll be immersed into a liquid, and that liquid will be centrifuged and used for liquid-based preparation, right? So conventional is IS spatula, make a slide as usual, and your the latest one is your liquid-based preparation. That's much more superior because it will remove all the waste particles, right? Okay, now let's do question part. Can anyone tell me what's a fixative used for pap smear? Something which keeps on routinely coming. What's a fixative we use for pap smear? You must have read this in gynecology as well. Fixative of pap smear is, it's your ethyl alcohol, right? Or ethanol. 95%, 100% yes. Fine. This is a revision session. Obviously, we will not be able to cover entire thing, right? It's 95% ethanol, 95% ethyl alcohol, or a 100% spirit, right? Spirit is generally not available. It's the fixative for pap smear, right? Ethyl alcohol, ethanol, alcohol, whatever it is, right? I also want you to remember one more thing, which is isopropyl alcohol. If ethyl alcohol is not there in the options, go for isopropyl alcohol, because 100% ethanol or 95% ethanol is very difficult to procure. It has an hazard that people might drink it and they might lose their eyes and everything, right? So isopropyl alcohol, which is comfortable to procure, most of the private labs in the country use isopropyl alcohol. Either it's 95% ethanol, that's the best, or an isopropyl alcohol. The very, very old MCQ of ether. Ether is not used anymore, okay? Ether was used, 95% ethanol plus ether. Ether is superior, but the only thing is ether is inflammable. I don't want the lab to burn for a nuclear architecture, right? So ether is not used anymore. It's pure 95% ethanol, that's all, right? And there's an adequacy criteria. One of the AIMS exam had adequacy of saying that what is the basic requirement for a thyroid FNAC. So there's a possibility they can ask for a pap smear also, right? Conventional pap smear, the routine slide I said, I need a minimum of 8,000 to 12,000 cells. Only when there is 8,000 to 12,000 cells in the microscope, I can say this is adequate enough for me to report whether it's a cancer, non-cancerous, or whatever it is, right? There are exceptions, obviously, but I need a basic of 8,000 to 12,000 cells, right? And for liquid preparation, since it's more concentrated, more centrifuge, the impurities are removed, 5,000 cells is good enough for me to say it's in liquid preparation. Okay, this is enough for me to call it an adequacy of pap smear, fine? Okay, so these are few things is required from a pap smear. And let's go to the second cytological procedure, which is FNAC. FNAC is fine needle aspiration cytology. Most of you must have seen FNAC being done, or some of you must have even done an FNAC, right? So FNAC, this is called as an FNAC handle, okay? So what we do in the handle is, can you see a tiny groove here? That's where the syringe sits. So the syringe sits here, and the body of syringe will be there, and needle will be here, right? So what generally we do is, once the syringe and the needle is kept in place, this will be pulled down. That gives a negative pressure. And then we poke the tissue, whatever tissue it is, a lymph node or a breast parenchyma or an salivary gland, whatever it is, we poke it, we give a negative pressure, and the material will be in this hub. That's all. I'll take a very tiny material and you will smear it on a slide, right? That's a fine needle aspiration cytology. Predominantly, the needle used is the blue color needle, which is used for intramuscular injection. If you want to know the gauge, you already know the gauge, right? It's a blue color needle. It's a commonly done one. But if I do an FNAC of a lipoma, bit difficult to remove, we can prefer green color. Bone soft tissue, bit difficult to remove, I can do a green color. But predominantly, it's a blue color needle, which is being used for FNAC, right? So now, FNAC, what are the stains done? There are two stains done for FNAC. One is your pap smear, another is your MGG or May Grunwald GIMSA, or in simple words, just remember GIMSA, okay? The most important thing I want to remember, GIMSA is only blue color. It'll have varying colors of blue, light blue, dark blue, like that. But it's only blue color. That's what May Grunwald GIMSA or GIMSA has, right? So fixative is based on the stain, okay? PAP, what's a fixative? The same fixative what we read till now, right? Same pap smear fixative, 95% ethanol only. May Grunwald GIMSA is an air-dried smear, okay? It's an air-dried smear. We dry the smear in the air, and then we do a GIMSA. GIMSA has everything, right? But PAP, definitely we are going to use the same 95% ethanol as a fixative. Fine. So different stains, different fixative, right? And like I said, adequacy for thyroid. Does anyone know the adequacy for thyroid? This is a PYQ. I'd want you to know what's the adequacy of a thyroid FNAC. Comment. If you make a mistake, I'll add it later on. Fine. But these are some things which I should make sure you should know about it. Fine. Perfect. Okay, and there's a repeated question. I hope you won't forget it. FNAC can never distinguish a follicular adenoma of a thyroid, not a cyst, adenoma of a thyroid, from a follicular carcinoma of a thyroid versus a follicular carcinoma of a thyroid, right? It's very, very important. FNAC cannot distinguish it because we need to prove a capsular or a vascular invasion to be present for us to tell you have a carcinoma, right? Great, Palash. I need at least minimum of 6 follicles, right? 6 follicles with 10 cells each. Only then I can call it an adequate thyroid FNAC. Then I can obviously report almost everything except for follicular carcinoma. I cannot identify follicular carcinoma on an FNAC because you need a capsule invasion or a vascular invasion, which can be done only post-surgical. You will not be able to identify your FNAC follicular adenomatous carcinoma pre-surgical. It's only post-surgical we can identify, right? Perfect. Now let's come to one more investigation. Frozen section. Does anyone know the name of this instrument? Starting with the name. It looks like a refrigerator with a handle here. That's where we used to cut the instrument, right? And this is the inside part of the same instrument. So we have a chunk, that's where the tissue goes, and we have microtome. Microtome is where we used to cut the handle. Handle's name is for the microtome's handle, right? Then the chamber will be in a very freezing temperature, and this instrument's name is cryostat. Cryos for your frozen, right? Perfect. Cryostat. Cryostat is the routinely done for frozen section, right? So that's a normal instrument which you do it for frozen section, fine. So cryostat, what do you have a fixative? Is there any fixative for frozen section? Can anyone tell me what's a fixative for frozen section? This is being asked in MCQ in a very different way. Frozen section actually does not have a fixative. It's fresh tissue, right? The freezing, the cold, the temperature is a fixative here, right? So there's no fixative here, no additional fixative. It's done on a fresh tissue. That's the entire advantage or logic behind frozen section, right? I did not have a fixative. I don't need to process. I generally freeze it and I do it. The special stain which can be done only on a frozen section is all the fat stains, because we know that if you routinely process a tissue, fat will be washed away. I cannot see them. The only place I can see fat as a fat and I can apply fat stain is frozen section. Do remember that, right? There's no fixative for frozen section. It's always must for you to remember that it's frozen. The temperature is the fixative, right? So since we have talked lots and lots of things about fixative, can anyone tell me what is the actual function of a fixative? What does a fixative do? We have been talking that, okay, I do an ethanol, adride, no fixative, formalin, right? The most commonly done fixative for histopathological examination is by default 10% neutral buffered formalin. NBF is neutral buffered formalin, right? What does a fixative actually do? Fixative does not fix the tissue to the slide. That's a wrong assumption. Fixative's role is simple. They have to prevent autolysis of the tissue. See, imagine you're taking a biopsy or a tissue from the body. I'm going to take it outside. Will it live? It won't live. It will die automatically. It will decompose, right? It has to decompose. Fixative is to prevent the autolysis. That's the first thing. Second thing is to avoid any secondary suprarenal infection. It's a human biological tissue. Fungus will grow, bacteria will grow if I keep like that, right? Fixative job is two things. It has to prevent the autolysis and also to avoid the suprarenal infection. These are the two main roles of fixative. Without fixative, cells will automatically die. And there are tissues with stains which are done with no fixative. One of the classical thing, if I have a stain which is no fixative, we call the stain a supravital stain. Can anyone name one single supravital stain? This is stain without fixative. They don't have a fixative, which means it cannot stay forever. After some point of time, cells will automatically die here. This is done for all the peripheral blood smears. I am sure you must have read about the peripheral blood smears. The commonly done is Leishman, and here we have a stain called new methylene blue, right? The new methylene blue stain is a stain without a fixative. That's why you call it a supravital stain. It stays, it's vital, right? Supravital stain is stain without a fixative, right? Perfect. Now let's go to this next guy. We have seen this guy in photographs, right? There are very few places in our entire country which has a live usable electron microscopy, right? Electron microscopy, I really don't use it for anything for your diagnostic pathology. Brilliant crescent blue is also a very good fixative, which also supravital stain. Fine, you are right, Palash. Yes, it is used to stain your reticulocytes. Fine, okay. So electron microscopy in diagnostic pathology is almost nil. Very rarely it's useful for renal pathology. Apart from that, we don't use it for anything for electron microscopy, right? It's purely for research purposes, right? So electron microscopy, I'm going to talk about only one thing, which is the fixative. What's a fixative for electron microscopy? And practically, I would say I might use it for renal pathology. Might. Again, not often. For renal pathology, we might use it. And for few rare neuromuscular disorders. The fixative is, we have two fixatives. I want you to remember both. Okay. Glutaraldehyde is a very good fixative for electron microscopy. We have some more column. Osmium tetroxide. Remember both, there is a huge list of fixatives which can be used for electron microscopy, but glutaraldehyde, osmium tetroxide are commonest thing. Rishabh, yes, you want to say about Romanowski stain? Romanowski is your Leishman, Fields, and all those are Romanowski stains, fine, okay? So the only use for me is your renal pathology. See, one thing which I want you to remember with respect to your electron microscopy is, electron microscopy has only black and its gradients, black color, gray color, and white color, that's all, right? So anything, when we use the term electron dense is equivalent to more darker or black, okay? That's why if you remember your renal pathology, we said that subepithelial electron dense deposit. Okay, it's an electron dense deposit, so it will be blackish in color, which I want you to remember. Not every electron dense deposit will be black in color. I will not be able to say what it is. It's electron dense and it will be black in color in case of an electron microscopic appearance. Fine, perfect. Then we have one more guy, fluorescent microscopy. Can anyone tell me any one use of fluorescent microscopy? You must have seen fluorescent microscopic images. The images are the one which is the green color, black color background, right? That's a fluorescent microscopic images. Can anyone tell the one use case of fluorescent microscopy? By the way, in fluorescent microscopy, I have two guys. I have indirect fluorescent microscopy and I have an direct fluorescent microscopy. Direct is your DIF, which is done routinely in diagnostic pathology. Indirect is primarily used for research purposes. We don't come across indirect fluorescent microscopy in routine pathology. DIF images you must have seen, na? Pemphigus vulgaris. What's the classical appearance? Fishnet appearance. That's your direct immunofluorescence. Your kidney biopsies, the linear, granular, mesangial positivity of glomerulonephritis, that's a direct immunofluorescence. In your autoimmune antibodies, the ANA, in your SLE you have your homogeneous stain, speckled pattern of immunofluorescence, that's an immunofluorescence, right? So for fluorescent microscopy, first the fixative is saline. Okay, saline is a fixative, right? Or I can, auramendrodamin for TB, right? Saline is a fixative. I can use fresh tissues also for fluorescent microscope, like a frozen, or there's a medium called Mitchell's medium. Mitchell's medium is a transport medium. This also can be used as a fixative for a fluorescent microscopic biopsies. It's very, very important. It should not be done on formalin tissue. If it's done on formalin tissue, the answer will be wrong. Like I said, the use case, the most important thing is GN is for glomerulonephritis. And for the, especially for the bullous lesions of skin. It's used for many things, but bullous lesion of skin is where an undergraduate knows it frequently, right? You have the pemphigus vulgaris, bullous pemphigoid, epidermolysis bullosa, right? So your dermatitis herpetiformis, all these places we use fluorescent microscopy, right? And also for your ANA profile, anti-nuclear antibody profile in case of an SLE, right? These are the commonest use cases, right? Okay. The stain, there are generally some very peculiar colors you will see. Red and green is the commonest used one. Fine. Among that, green is the commonest used one. So the green color, which is positive, is because of a dye called as an FITZ, fluorescent isothiocyanate. It's a cyanide dye. Okay. Fluorescent isothiocyanate, that's the commonest used dye here, right? True. Those and all goes into microbiological perspective, right? Your oramen, rhodamen, acridine, orange, everything, right? In pathological perspective for biopsies, I use FITC by default. Rarely I can use neutral red. Neutral red gives the red color. Also, it's used in some places for fluorescent microscopy. Most of the time, I use FITC only, right? Since we are here, previously when INICET had a question, what's the stain for immunohistochemistry, which gives the brown color? And the stain is named as DAB, diaminobenzene, okay? Diaminobenzene is the brown color which is there in case of an immunofluorescence, sorry, in case of an immunohistochemistry, normal IHC stains, what to use for your ERPR, HER2 and every other immunohistochemistry, we have DAP, right? Perfect. So one question, which was a very old repeat question from AIMS exams, there is one very particular mirror which does the entire function of fluorescent microscopy. First, if this image is given, how do I differentiate from a normal microscope? Normal microscope will not have this attachment. The light comes from the side. In case of fluorescent microscopy, normal microscope, light will come from the here, right? That's one main difference. I can easily say there's a back attachment. It's not a normal microscope. It's a fluorescent microscope. Fine. No, Palash. Congo red is a polarized light. It's not a fluorescent microscopy. It's a normal microscopy with a different light. There's a filter. That's all. It's a filter what we use in a normal light microscopy. It's not a different microscope at all. Fine. Okay. So now, what is the uniqueness is there's an important mirror called as a dichoric mirror. That's very, very important. Like I said, the light comes from the side, goes, hits the specimen, and it is returned back to the eyepiece. But the eyepiece, I should be able to see only the green color. That's why the background becomes black. That's dichoric. Dichoric mirror will reflect all the spectrum of light, a white light. It will reflect a white light, but it will allow only one wavelength of light. That's a green color or red color or yellow color, right? So that is dichoric mirror. Two colors. It will reflect one and will allow it to pass one. That's very, very unique for fluorescent microscopy. You have to remember this. That's the important component of fluorescent microscopy. And that's the reason the background of fluorescent microscopy is always black. It's not white. It's always black. A normal microscopy is always white, right? And like Palash asked, your polarized light is something different from this. Polarizing microscopy is just a filter. It's a filter added to a normal light microscope. It's not a different microscope. It's just a filter. If you guys have an access to the pathology lab, you might have the filter at home. The 3D glasses you use is a polarizing filter. If you have at home, take the 3D glass, keep one of the glass on top of this light, one of the glass below this light. It's a polarizing filter. That's all. Okay, it's not any new microscope. It's a filter added to a normal microscope. Fine, perfect. Now let's go to this guy. This is where the heart of histopathology is. Almost every histopathological sample which has been processed is done using this. This is called an automated tissue processor. You must have read that processing is the one which dissolves fat. Processing takes approximately 15 to 20 hours. So I put in the night. The next day morning only the tissue becomes normal. Okay. In processing, what we do is we use gradations of alcohol or increasing grades of alcohol like 50 to 60 to 70 to 80 to 90% of alcohol is used. The reason for using this alcohol is alcohol will slowly remove the water. It will dehydrate the tissue because if it's very hydrated, I will not be able to cut. I have to make it a little bit drier, right? So it will dehydrate the tissue. But once it's dehydrated, what happens is inside the tissue, alcohol will sit there. I have to remove the alcohol. Otherwise, I'll see in microscopy full of alcohol, right? So for that, we use xylene. Xylene was asked once in exam. Xylene is a clearing agent. Okay, it removes the alcohol and makes it empty. And after that, what we do is we embed it in wax, right? So after xylene is done, we use paraffin wax, and wax is used for embedding of the tissues. Which means ideally inside the tissue, all the empty spaces, I have wax. When it's cut, it becomes empty. That's all, as simple as that, right? And fixative, like I said already, for all the histopathological samples, your neutral buffer formalin. Very, very old question. Once it was asked, Boyne's solution. Does anyone know where do we use this? Real use case, almost nil. But do you have any idea where we use Boyne's solution? Boyne's is primarily useful for testicular biopsies. Okay, the primary use case for Boyne's is testicular biopsies. Where we were using it, even now if you ask me, is it better? Yes, slightly better, but Boyne's has few hazardous mercury which might affect the patients, the people who are working in the lab. Still, I would say I prefer a neutral buffered formalin for real use cases, fine. But yes, it was used for your testicular biopsies, fine. Okay, perfect. Now let's go to few stains. There's a stain here, and what is going to be seen on microscope, right? Mesenfantana, where do you use them? I'll show you the stain. You're going to tell me where you use them. Everyone knows mesenfantana. Mesenfantana stain for melanin pigment, right? Previous NEET or INICET had a question that melanin everyone knows. So slightly they changed the question. Pigmented fungi, which also is melanin pigment, right? There also mesenfantana will be useful by default. I use it for melanin. Any pigmented lesions of the skin, we can use it. Okay, your nevus, melanoma, vitiligo, absence of stains in vitiligo, right? So any pigmented lesions of the skin or depigmented, we can use mesenfantana, and also use it used for fungal lesions for identifying fungus, but only pigmented fungus. I cannot see every fungi here. A pigmented fungus, the pigments can be picked up by your melanin stain. That's your mesenfantana, right? There's one more stain called Schmorell stain. We'll go with one. At least you'll remember one. If you can recollect that in the real exam, that will be amazing, right? Okay. PAs. What are the use cases? Where do you see PAs? There are lots and lots of places we see PAs. What are they? PAs, glycogen, mucopolysaccharides, fungi, and also PAs will stain protein. The many use cases of PAs, but two things you want to remember: glycogen is one, protein is one, right? Fungi also is stained by PAs. Fungi is very sensitive stain, right? So if it's glycogen, PA has one modification, that is PAs positive. Diastase is the enzyme, and it will be sensitive to diastase digestion. That's for PAs, right? How I can use this? The use case is simple. I can give you a simple history of Pompey's disease. 2-year-old child die of cardiac failure. Biopsy shows pinkish clear areas with PAs positivity, diastase sensitive. I'm telling it's a glycogen accumulation, glycogen storage disease, heart involvement, Pompey's disease. So you can easily create a scenario-based question, right? Same like Sanvi said, alpha-1 antitrypsin deficiency. Here it is, PAs positive, diastase resistant, because here is a protein. Proteins are PAs positive and diastase resistant. Wherever it is, they are PAs positive, diastase resistant. One more thing which is PAs positive and diastase resistant is your Whipple's disease. The organisms in the Whipple's disease, Triforma whippli, here it will be seen in the macrophages. The macrophages in Whipple's disease will be PAs positive, diastase resistant. Do remember them. Fine. Okay. Perfect. Okay. And the normal color of PA is magenta color. That's the normal color of how it looks in your microscopy. If it's positive, negative, it obviously is going to be look clear in color, right? And glycogen can have two colors, can be white or can be light pink. Both will be the appearance of glycogen based on the density. That's all. Fine. Okay. Perfect. And this guy, fat, stain for fat. Already we know one question. I can use fat stain only in frozen section when there's no processing, when there's no fixative. And there are two stains for fat. One is your oil red dough, other is your Sudan black, right? So Sudan black has multiple things. Sudan black B, Sudan black V, everything, right? I use it for two, and this image is obviously the image of an oil red O, but I can use for also Sudan black. All the variations of Sudan black can be used for your fat stain, right? Sudan black B, 4, 5, everything, right? All of them do stain your fat. Fine. Okay. Iron, hemosiderin, everyone knows the pigment. The stain is your Pearl's Prussian blue. There's nothing difficult to remember that. It's strongly marked, right? It's iron stain, where microscopy you will have a golden brown color or brown color, and obviously in a Pearl's Prussian blue, it becomes bluish in color. I can use it for quite a few disorders of hematology, where I see ring sideroblast or a normal iron stores in your bone marrow, where all I can use. I can see, let's take a detour and see if we can identify that. I'm saying in a lung biopsy, okay, I'm seeing Pearl's positive granules inside macrophages. Okay, granules are seen, Pearl's positive inside macrophages, and I see fibers, elongated fibers, which is Pearl's positive inside the macrophages or in the lung biopsy. Can anyone tell me what could be diagnosis here and what could be diagnosis here? See, these are the application of Pearl stain. Everyone knows Pearl stain, right? So where do I apply? How do I integrate it? Come to a diagnosis is what the intelligence about. Fine. Granules, lung biopsy, Pearl's positive is nothing but hemocytin latent macrophages. This is your heart failure cells. Heart failure cells seen in case of heart failure in the lung biopsy. And the fibers, I'll rephrase this question. Everyone will know it. These fibers are dumbbell shaped. Now everyone will jump and answer the question. These fibers are seen in patients who are working in a cement insulation industry. That's your asbestos fibers or ferruginous bodies. Okay. See, if I throw an image of ferruginous body, if you can pick it up, good. But you should be able to correlate. That makes you go to the next level, right? The correlation is very, very important for INICET exams. Please do remember them, right? So it's a simple ion stain. I can have multiple outcomes and application based on that. Fine. Perfect. Okay. What's this guy? That's your beautiful pseudomonas calcification, right? Pseudoma body calcification is going to be a little bit bluish in color in a light microscopy. And everyone knows the mnemonic for calcification. It is KALCIUM, right? Every pathology resident knows this, right? It is COSA for von COSA, AL for alizarin red, okay? And the most important thing, von COSA is the most commonly done stain. Alizarin red is the very, very, very specific stain, okay? It's very specific stain because alizarin red can pick up even tiny molecules of calcium. But von COSA needs a salt of calcium to pick it up, right? And alizarin red, as you see in microscopy, it will look reddish in color. And this is how von COSA looks like. There's an image of von COSA. It will have brownish black in color, okay? Let's see if you can identify diagnosis. The goal is diagnosis. The goal is not remembering the facts. I'm saying these are blood vessels which are positive for von COSA. Can anyone tell me what's the stain? Blood vessels positive for von COSA. Can anyone tell me what's the stain? That's Monkeyberg's medial sclerosis, right? I'm sure you must have heard about a disease called Monkeyberg's arteriosclerosis or Monkeyberg's medial calcification, which is nothing but an age-related calcification. That's what we see here, right? Like I said, ultimately what you need is application. Everyone knows the calcium stain, right? I'm going to say calcium positivity in an ovarian biopsy, pseudoma bodies, serous cystadenocarcinoma. Application is what is being tested in any scenario-based question. Fact everyone knows. Fact is not the problem. Application is the problem. Please train for that. Fine. Okay. And we know Congo red. Congo red is stained for amyloid, like Palash already said. There are two things in Congo red. Congo red in a normal light microscopy will have, not apple green birefringence, will have the salmon pink color. The same Congo red, when it goes to polarized light, it becomes your apple green birefringence. Okay. That's the classical appearance of Congo red in polarized light. And that's the classical apple green birefringence, right? So any other use case of polarized light apart from your amyloid? Everyone knows about amyloid. What's the other use case? Where else I can use? Polarized light in diagnostic pathology, minimum to minimum. I can use them in gouty arthritis. Gouty arthritis are negatively birefringent, needle-shaped crystals. You know that, right? Silica particles. Silicosis. They are positively birefringent particles, right? These are the other use cases where I can use polarized light. Talcum powder, foreign body, is also will be birefringent under polarized light, right? These are use cases apart from amyloid where I can use a polarized microscopy. Okay, great. This is a stain of liver biopsy. And this, I'm using a stain called as a reticulin stain. Reticulin can pick up fibers, right? There are fibers called as reticular fibers. The two things we want you to remember. Reticulin can pick up liver fibrosis, reticulin can pick up bone marrow fibrosis. These are two common fibroses which reticulin can easily pick up. Both in liver fibrosis, that's your liver cirrhosis, reticulin can pick up the nodules, and also in myelofibrosis, bone marrow fibrosis, it can pick up the fibers. Okay. Second thing which I want to remember is, this is an old MCQ names, a beautiful question. All of the following structures have reticulin except, right? All have reticulin except one organ. That organ was thymus. Thymus lacks reticulin. Please do remember them, because you must have read about a system in your first year called as an reticuloendothelial system. Liver is one, spleen is one, bone marrow is one, lymph node is one. All of them have reticular fibers and endothelium, sinuses. Liver has sinus, bone marrow has sinus, spleen has sinus, your lymph node has sinus. Thymus is also reticuloendothelial, but they don't have reticular fibers. It's an outlier. Outliers always come in exam. Please do remember them. Fine. Okay. And this is the GMS. Gomori methanamine silver. Any silver stain will be blackish in color. That's a clue for you. Okay. For example, Gomori methanamine silver is for fungus. There's a beautiful fungal hyphae we can see. That's also black in color. We have something called an Warthin-Starry stain. Does anyone know where you use it? Warthin-Starry, that's also silver based. It will be black in color. Reticulin is black color, silver based, right? We have VVG stain. Where do we use VVG stain? Which also is a silver stain, black in color. Warthin-Starry is used for syphilis, spirochetes, H. pylori, any tiny organism I cannot see in microscope. I use black color stain. VVG, I use it for elastic tissues, elastic fibers. Again, they are very, very tiny. I use your silver stain, make it black in color. That's a basic concept of any silver stain, right? Perfect. Now, you can actually identify this hyphae, identify the organism. Can anyone tell me what's the organism here? This is a classical finding here. Look at this. It's branching like this. That's a based on the branching and acute angle 45 degrees septate branching we have for aspergillus. Okay, and a straight angle, a bulbous end, a 90-degree branching is for the rhizophus or the mucor. Mucor is one, the right angle branching, that's very, very important. And also the ends will be little bit rounded, right? A bulbous end. Both are very classical for an your mucormycosis, fine. So this difference also has been asked in exam. Do remember them, right? Last but not the least, can anyone tell me where this is used? Though the practical use case is almost nil, because I don't take a biopsy for this, right? So this is your myelin stain. We use it for demyelinating disorders. No one takes a brain biopsy for demyelinating disorders, right? It's a clinical diagnosis and an MRI can easily pick it up. But Luxol Phos Blue is a myelin stain. I can use it for a demyelinating disorder by default, right? Perfect. Done. So these are few special stains which I want you to go through in the final go. Before the exam, it's not about the stain, it's about the application. I can have a demyelinating disease history and say this patient is having HIV positivity or an immunocompromised state. I think of a progressive multifocal leukoencephalopathy, JC virus, right? Dawson fingers, demyelination. I might think of a multiple sclerosis, right? So what is required for me is the history and the application and not just the stains. Stains are the first level of entry. For an integrated question, you'll have to apply and make it a right one, right? Now let's go to the next guy. Countest IHCs. I'm going to use a list of IHCs where I feel that is important for you to know in the last go. We look at the CK7, CK20 panel at the last. Fine. That's one of the repeated questions. These are the positive for CK7, 7 positive, 20 negative, both positive and all those things, right? I have told this before already. The counter stain is DAB, diaminobenzene. One by one. Fastest finger first. Where do we use TTF1? TTF1 is used in which tumor? It's used in, you know the answer, it's used in lung adenocarcinoma, right? It's an not just lung cancer, it's marker for lung adenocarcinoma. It will be marker only for lung adenocarcinoma, not for any other adenocarcinoma, not for squamous cell carcinoma of the lung also. It's lung adenocarcinoma, right? Perfect. Okay. Rishabh, this is just a marathon. So the final thing, right? ERPR is for breast cancer. Okay. HER2/neu. This I want you to remember. I think because one of the pharmacology question in INST had the target of ERB-B2. ERB-B2 is the other name for HER2/neu. ERB-B1 is your EGFR, right? HER2/neu is also for the same breast cancer. PSA, prostate specific antigen, is for prostate origin. There's a marker called an AMACR. AMACR is very specific for prostatic carcinoma. BPH will be negative for AMACR, right? This is more specific for prostatic carcinoma, because PSA will be positive for both normal tissue as well as your prostatic tissue, right? As well as your malignant tissue. So it is a sensitive test, but AMACR is very, very specific because it's for prostatic carcinoma alone, right? Synaptophysin chromogram is for neuroendocrine differentiation. And there was one more question, marker which was recently asked, insulinoma associated protein, right? Okay, insulinoma associated protein, INSM1. That is also a marker. That's a nuclear marker for neuroendocrine origin. Please do remember one. Okay, there's a new one which is asked in previous INICET question, insulinoma associated protein stain, which is a nuclear antigen. Okay, synaptophysin your chromogram, cytoplasmic one, INSM1, not INSM1, it is INSM1. Fine. CD99, a very old one, I would say pretty useless in terms of diagnostic pathology. CD99 or MIG2 was used as a marker for Ewing's PNAT. This is more of an undifferentiated cell marker. I said useless because leukemias, lymphomas, most of the small round blue cells will be positive for that, right? It's not very useful. Ewing sarcoma or a PNAT, I would prefer FLY1, new marker, super marker, and NKX2.2. These are the best marker these days. No one does CD99 in diagnostic pathology these days. Either FLY1 or your NKX2.2 is a transcription factor, right? CD117 is the most common stain useful for GIST, gastrointestinal stromal tumor. Dodge1 is a very specific marker for GIST. Don't forget that. You need not memorize it. DOG stands for discovered on GIST first. That's not a mnemonic. That's how the marker is named. It was first discovered on GIST. You should have named every marker like this, no? Discovered on Ewing sarcoma first. Life would have been much easier, right? Dodge1 is discovered on GIST first. That's a very specific marker for GIST, fine? Melanocyte marker. S100 again is a sensitive marker for me. HMB45 melanase is more specific. Okay? I'm adding one more new marker for you guys. If it comes in an exam, it'll be jackpot for us, because these days the reliance on HMB45 and melanase is reducing, because there are quite a few types of melanomas which are negative for HMB45 and melanase. So for diagnostic pathology, we have a marker called PRAME. Okay, PRAME. It's a preferential antigen expressed on melanoma. That's what PRAME's abbreviation stands for. PRAME is much more superior and much more specific for malignancy, for melanoma. Do remember that. These days we use PRAME. We are reducing the reliance of HMB45 and melanase. If it comes in an exam, it will be great for us, right? It's preferential antigen melanoma expressed. That's PRAME, fine? Okay. Then 20 is for B cell, CD3 is for T cell. To know the lineage, very basic difference, right? Ki67 is your proliferation index. One question which keeps repeating, tell me a tumor which is close to 100% Ki67. What's a tumor? There's one tumor where the Ki67 is too close to 100%. What's the tumor? Close to 100% Ki67. That's Burkitt's lymphoma, right? There's only one tumor which is close to 100% Ki67 is Burkitt's lymphoma. Actually, it's diagnostic. No other tumor even comes close to that. So only one tumor which comes close to Ki67, 100% is Burkitt's lymphoma. Fine. So it's a lymphoma, Hodgkin's, right? We have classical Hodgkin's, we have NLPHL. These are the see. If I have to go with one marker for classical and NLPHL difference, I will prefer PAX5, because PAX5 has to be weakly positive in case of a classical Hodgkin's. It should not be strong. Okay, it should not be strong at all. PAX5 should be strongly positive in case of a NLPHL. It should not be weak. That's one where I have both the place positivity and both the places differential positivity. Fine. And obviously classical will be 15-30 positive. NLPHL will be 15, 30 negative, and CD20, CD45 positive, right? Right? These are two classical things. Fine? Perfect. Now, let's come to a big table. It's a table from Harrison, a very good useful table for CK7, CK20. Okay? I'll mark a few things which I want you to remember for sure. Please remember, one easy way to memorize this. Upper aerodigestive tract. Anything above ligament of Treats, upper aerodigestive. Lungs, little bit of breast, and your salivary glands. That also is upper digestive, right? This is CK7 positive. Lower GIT, CK20 positive. Okay, colorectal, CK20 positive. Add one more thing, Merkel cell. Merkel cell actually is an dot-like positivity, a very specific for CK20 for Merkel cell carcinoma. Dot-like positivity, right? When I say CK7 positive, 20 negative, upper aerodigestive, lung, breast, ignore thyroid. I don't want you to remember. Endometrium, don't want you to remember. Don't want to remember. Remember this. I'll tell you why rest not required to remember. It is not consistent. No one does CK7 for thyroid or endometrial. And pancreatic cholangio, you see here also. It is not consistent. If it is not consistent, don't remember. For an undergraduate level, need not remember at all. If it's consistent, remember. So I want you to just remember your breast, thyroid, salivary gland, and also upper GIT. Here they don't mention upper GIT for the simple reason I don't want markers for upper GIT. Stomach cancer I can diagnose in histopathology itself, right? So this is how your CK7 positive, CK20 negative is. Both positive. Remember these two guys alone. Enough for me. Urothelial, ovarian, mucinous adenocarcinoma. That's all. Again, these two don't remember because it's overlapping. If it's overlapping, gray area, not for undergraduates. Both negative, right? I want to remember hepatocellular carcinoma, renal cell carcinoma. These three, I don't rely on CK7. For head and neck carcinoma, we rely on squamous, we do P40, P63. I don't even come to CKs there. Prostate carcinoma, PSA marker. I don't even do CKs there, right? Hepatocellular renal cell carcinoma is bi negative, CK7 as well as CK20 negative. CK20 positive is your colorectal carcinoma. CK7 positive is your upper aerodigestive tract. Remember, upper aerodigestive includes all entire GIT, salivary gland, lungs, and breast. Kind of the upper GIT. That's for your CK7 positivity. Both positive is your urothelial and ovarian carcinomas. Fine. Perfect. Done. Okay. So these are all the must needed marker for you to go before the exam, right? There might be few things left. For me, in the last moment, if you can remember this, I can have a 80 to 90% similarity in the exam. That's the goal. 100% is never the goal, right? Okay. Now let's go to few things in hemat. We'll go with basic hemat. What I'm going to do in hemat is, we'll use the image and try to revise the entire topic wherever it's possible, fine? Leishman is the most common done stain. It's a Romanowski stain. It's the most common done stain for peripheral smear. Fixator for Leishman is acetone-free methanol. It's methyl alcohol, but it's acetone-free. Why acetone-free? Because acetone will cause hemolysis. So we remove the acetone so that I don't want hemolysis there, right? Supravital, new methyl blue, no fixator. Brilliant crystal blue, crystal violet, all of them are supravital. Again, the most commonly done is new methyl blue, where we use it primarily for reticulocyte stain. It's a stain for reticulocytes to count reticulocytes. Fine, perfect. Now, this is the image. Okay. First, before going to the image, what's the normal shape of RBC? Let's make it a little bit easier so that you guys will also involve in the discussion. What's the normal shape of an RBC? The normal shape of an RBC? Biconcave, right? Perfect. So here, normally the RBC is biconcave disc shaped. Because of this, hemoglobin stays here. Hemoglobin stays here. So center part, there will be no hemoglobin because it's been compressed. That's the reason in a microscopy, a normal RBC will always be pale in the central. Central 1/3 has to be, will be pale. It will be pale, right? And because I'm looking from the top, I'm not looking at the RBC from the side, I'm looking from the top. That's the reason I have central 1/3 pale. This is normal for every RBC. If it's not pale, I have a problem. If it's more than 1/3, I have a problem. More than 1/3, I call it hypochromic, less number of hemoglobin, amount of hemoglobin, right? If there is no pallor, like this. Look at this. Is it pale? No, no. But this guy, these are pale, na? Yes. The ones which are circled compared to the one with arrow marks. The arrow marks has no paler, little bit smaller, little bit darker as well. That's a classical finding for what cell? I have a dark cell, I have a small cell, and there is no central pallor. Right? So what do you call this? We call this spherocyte. Right? A spherocyte will be smaller, darker, and no central pallor. The moment you see spherocyte, it's a very old AIMS question, repeatedly asked. What's the next test you will do? The next test you will do is, you look for, next test. You look for, or you do a test of Coombs test to rule out autoimmune hemolytic anemia, right? Because the most common cause of spherocytosis is autoimmune hemolytic anemia. It's not hereditary spherocytosis any day. And for me, the next step when you see a spherocytic anemia is to rule out autoimmune hemolytic anemia, to do Coombs test. Okay, you have to do a Coombs test to rule out autoimmune hemolytic anemia. If its Coombs is negative, then yes, there's a possibility that it could be hereditary spherocytosis, right? Few things to remember as spherocytosis. It can involve multiple mutation, but the most common gene mutated is ankyrin, spectrin, band 3, band 4.2. All of these are structural proteins. So spherocyte is an autosomal dominant inheritance. When it's an autosomal dominant inheritance, they present predominantly late in life, right? They present as adults. You see this triad, adults, you have splenomegaly, because spherocyte will have extravascular hemolysis, plus you have your gallstones, pigmented gallbladder calculi, you think of a spherocytosis, right? That's one classical group of spherocytosis. Very, very, very rarely spherocytosis can be present in children because of autosomal recessive inheritance. Not common, but very rarely can be present in children, especially in spectrin defect, because spectrin can be autosomal recessive inheritance also, very, very rarely, right? Perfect. Now, what's this cell? Classical finding. What's a cell? That's your bite cell, right? Everyone will definitely talk about it. It's a bite cell, right? Everyone knows what's a bite cell, right? Where do you see bite cell? Bite cell is classically seen in G6PD deficiencies, right? As a classical bite cell, it's a bite cell. More than bite cell, for me, the clues for G6PD deficiency is X-linked recessive inheritance. So most commonly involving men. The clue is the trigger. This is a trigger-induced hemolysis. Post-infuction, post-drugs, you know, the primaquine, the dapsone, and post-fava beans ingestion, right? Post all these, you have an hemolytic anemia. I think of G6PD. More than bite cell, history is important for me. History is the only thing which is important for me. Patient is the only person who is important for us, right? So, and obviously, like Subhajit said, in new methyl blue stain, I can see an inclusion cause in Heinz body. Heinz body is nothing but a destroyed, denatured globin. Okay, it's a denatured globin. That's your Heinz body, which can be seen in new methylene blue. Investigation of choice by default is this enzyme analysis. You analyze the enzyme, say it's low, that's all. It's a very transient hemolysis, automatically will come back to normal once the infection goes away or the drug has been stopped or ingestion is being stopped. Fine? Okay. What's this guy? That's a very classical, right? Yes. Degma is the white. Fine. That's a very, very classical sickle, right? Since you said degma, sickle is also known as drepanocyte, right? Like a boat. You need not always see a sickle like a sickle. Actually, this also sickled. This also sickled. Please don't always look at this beautiful sickle and only then call it. Something flatter, something a little bit curved on the end. Also, I can say probably it's a sickle cell anemia, right? Right? Rishabh, it's not pencil-shaped cell. Pencil-shaped RBC has seen iron deficiency anemia, where it will be pale. Please remember, pencil is always for idea where it will be pale, right? And also, what is this guy? You see, target cells also, right? Target cells also can be seen in sickle, though it is classical for thalassemia, but I can see them in sickle cell anemia also. Do remember that, right? Sickle, autosomal recessive disorder. The most important thing I want you to remember sickle is the vaso-occlusive crisis. Sickle does not present as your anemia most of the time. Okay, sickle mostly presents painful episodes. Anemia will be there, but they'll present as painful episode mostly. Very random, recurrent, unknown cause of abdomen pain could be sickle, right? Dactylitis, fingertip pain could be sickle. Non-healing ulcer, one of the possibilities is sickle. Priapism, one of the possibilities is sickle, right? So this is the presenting symptom most of the time, the vaso-occlusive crisis. Okay, this is enough for me to identify in a microscope peripheral smear. You see a sickle by default, right? But if I don't see a sickle, since it's autosomal recessive, there's a possibility of carrier state. I may not see sickle. So there's a test called a sickling test. Does anyone know the chemical what use of sickling test? Gaurav, I would want to stick to 6th position because it's very complicated for you to understand why 7th or why the change of 7th happened. Let's stick to 6th itself. Sickling test. Sickling test is used for recessive conditions, trait especially when I am not able to see a clear-cut sickle, I push them to become sickle. Because one of the biggest reasons for sickling is the deoxygenation. Fine. Amazing question, Rishabh. This is a very basic thing. See, in autosomal dominant inheritance, what we have is the problem is one allele mutation or one copy mutation will cause a cancer. Sorry, will cause a disease, right? So I have two copies of every gene in my body. One copy is gone. Other copy is there, na? It can help me to live for some time without symptom. Autosomal recessive, both copies are gone. No normal copy. They present early in life, right? That's a goal for every dominant, every recessive inheritance. Fine, Rishabh? Okay. Sickling test we use. Okay. Sodium metabisulfite. So sodium metabisulfite, what it does is it's a reducing agent. It removes oxygen. The moment it removes oxygen, it will predispose to sickling. That's something which is very, very classical to push the trait people into full-blown sickle cell anemia in microscope for me for diagnose, right? Sickle, one of the treatment for sickle is hydroxyurea. That's also based on the same concept of oxygenation. Hydroxyurea, one of the mechanism of action is it increases HbF. That increases the oxygen concentration inside RBCs. Because HbF can hold lots and lots of oxygen and they won't leave them outside. Fine? Okay. So which is whatever you said is for cancers, right? Not for other things. For other inherited conditions, we won't have the second mutation at all. Okay. For cancers, yes, the nuts and 2-8 hypothesis, whatever you said is absolutely right. Fine. Perfect. So what is this guy? That's like you guys said, there's a classical target cell or a podocyte. Fine. Target cell or podocyte, everyone knows. I'm going to see them in thalassemia. You see them classically in thalassemia, right? Thalas means sea. It was discovered in and around the Mediterranean Sea. That's why they named it thalassemia, right? So you have multiple guys here. We have thal major. We have thal minor. Let's not go into thal intermedia for now. For undergraduate, major and minor is more than enough for me, right? And we'll talk about beta thalassemia first. The first thing, in beta thalassemia, beta chain will be absent and almost every symptom is due to excess of alpha chain. Excess alpha chain cause symptom in case of thalassemia. Beta chain will be less in case of a thalassemia minor and absent in case of a thalassemia major, right? Thal major, thal minor, it varies from presentation. Presents around 6 months. It will not present at birth because at birth I have hemoglobin F, no beta chain, right? It is during adults. It's almost like an iron deficiency anemia. Mostly incidentally diagnosed. Adolescents, adults. Thal minor, right? Thal major, microscopically, target is common for both. But the moment you see NRBCs or NRBCs, nucleated RBCs, or a normoblast in peripheral smear, Okay, I'm talking about peripheral smear. I think of a major. I won't see them in minor. Minor, it will not be there. Severe anemia, even the normoblast comes out in the periphery. Very classical for thal major, right? In a HPLC or an hemoglobin electrophoresis, okay, the classical guy, HbA2 level, will be, I would say, more than 3.5, right? Let's not complicate much. More than 3.5%, I think of minor. Major also has it, but not classically. But what is more important for me in major is there will be no HbA and there will be very, very, very high HbF. Here, HbA also will be present because thal minor, only one is abnormal, na? Other will still produce normal HbA. HbA2 more and HbF not there, HbA there, thal minor, no HbA, very high HbF, you think of thal major. As simple as that, fine? Okay. With respect to alpha thalassemia, the first two variants will ignore. The only difference is alpha thalassemia or alpha chain has 4 alleles. So I have 4 different types of diseases. Okay, they are not like biallelic like every other gene in a body. Has 4 alleles. Fine, it's 4. So alpha thalassemia, the HbH is the 3 allele or 3 alpha deletion. Okay, it's like beta thalassemia major. So here in microscopy, we have a classical finding called as golf ball inclusions. We see them in new methylene blue stain. That's a classical for HbH disease. Okay, 4 alpha deletion, right? If 4 alpha is deleted, that's the worst condition where you'll have intrauterine problem. The kids have hydrops fetalis. I lose the kid before birth, right? Hydrops fetalis, because here I'll have, instead of alpha is gone, so I'll have gamma 4 in the hemoglobin. We call this hemoglobin Bart's. Bart's hemoglobin. Oxygen will never even go to the tissues. Every oxygen will be stored in the RBC itself, will not give it to the tissues. Full hypoxia results in hydrops fetalis, right? That's for alpha thalassemia. And one important thing, if I say investigation of choice is a beta thal, I would still prefer HPLC better than hemoglobin electrophoresis. If it's alpha thal, if I want to diagnose in totality every alpha thal, I cannot use HPLC. Few variants of alpha thal, yes, HPLC definitely helps, not denying that. Every alpha thal, my diagnosis by default genetics, I have to go for globin gene study. Again, it's only with alpha thal. If it's a beta thal, I prefer still HPLC. Don't want genetics because I can diagnose easily with HPLC. Major, minor, intermediate, everything we can diagnose with HPLC. Alpha thal, I cannot, so we for globin gene study, right? Now, let's go to the next guy. We know a little bit about hemolytic anemia, what is required, right? So based on MCV, we do classify the diseases. We have microcytic. Though I hate this mnemonic, I want to change it. I want the iron to come first. Only 2 things I want you to remember. One is iron deficiency anemia. The other guy is thalassemia. Other 2 I don't even want you to remember. No, anemia of chronic disease, not microcytic. It's a normocytic anemia. Sideroblastic is microcytic, fine. But sideroblastic is extremely, extremely rare. You might not see case of sideroblastic anemia at all in your life. Iron deficiency anemia, thalassemia, very, very important. And for these 2 to differentiate, there's one important question which keeps coming. 2 guys, your RDW and your Menster's index. Fine. We already know the logic behind this in our regular classes. Now it's just to revise fastly. A very stupid and easy mnemonic, thalassemia. Okay. So both RDW will be less or normal and Menster's index will be less than 13. Here you'll have a narrow or a not reduced RDW and less than 13 Menster's index in case of a thalassemia. So in IDA, obviously, it will be more than 13 and there will be a wider RDW in case of an IDA. Okay. Remember that. Fine. Okay. Sideroblastic anemia. See, I have genetic variants of sideroblastic anemia. The only problem here is iron is present. Iron, I am not able to utilize it. That's a problem with sideroblastic anemia, right? So here, one of the treatment initially given was pyridoxine. Do remember that this came once in the exam. Because vitamin 6 deficiency also causes sideroblastic. So pyridoxine sometimes work. Some drugs cause sideroblastic. But for genetic variants, pyridoxine will not work. For the acquired things, pyridoxine do work for sideroblastic anemia. And in sideroblastic anemia, I have an inclusion body called as an Pappenheimer body. Okay, Pappenheimer body is an inclusion body seen in the RBCs, seen in case of sideroblastic anemia. Fine. Okay, let's go to normocytic. Two cases for normocytic. One is anemia of chronic disease. Very important for normocytic anemia. Okay, I will have in microscopy both microcytes and normocyte, but diagnostic MCV is normocytic only, right? And then you also have anemia in CKD. In CKD, you have anemia because of reduced erythropoietin, right? Reduced erythropoietin we have, fine. Dhruv, I do have iron study abnormality. Again, like I said, Dhruv, sideroblastic is a bit of a complicated disease. I cannot categorically say like iron deficiency anemia, it's normal or reduced. It can be normal or reduced. It will be like that. So it's a bit difficult for you to remember it. So go for the history, microcytic, Pappenheimer, that's classical for sideroblastic anemia, and the iron is not being utilized, right? So that's a pathogenesis for sideroblastic anemia. It's not very easy to say left gray, black or white. It's in between the gray, fine. Okay, perfect. So he has reduced erythropoietin. So treatment is give erythropoietin in case of an and anemia of chronic disease, fine. Macrocytic, you know, megaloblastic is reduced B12, reduced folate, fine. And obviously other guys, you have alcohol, you have liver failures, you have hypothyroidism. In all these places, I'll have macrocytic, which is non-megaloblastic. Fine. Okay. I just want to add one more thing. This is more for a practical application. See, we always read that macrocytosis is MCV more than 100, right? Microcytic is MCV less than 80. Normocytic is 80 to 100. These are adult values. These are not for kids, not for infants. For an infant, even a 90 MCV is macrocytic. It varies based on age. For an undergraduate, I don't want you to remember it based on age. It's adults. Let's take care of that. But please do remember, when you're an intern or a post-intern seeing patients, macrocytosis, microcytosis will be based on the age. Please look into that. It will not be the same. Not just macrocytosis. Hemoglobin is based on age. TCDC is based on age. In a child, 50%, 60% lymphocytes is normal. In an adult, it's not normal, right? Please do remember, it's a practical tip. Whatever we read is for adults. Children, it varies a lot. Fine? Okay. Now, since we are iron profile, we look at iron profile, right? I want you to remember basic thing, two diseases in iron profile. IDA and anemia of chronic disease. Okay. So iron profile, these are the four basic iron profile required, right? These two guys are directly proportional. These two guys are inversely proportional, which means iron reduces, saturation reduces across the disease. Doesn't matter which disease it is. It's the same. Iron increases, saturation increases. Ferritin increases, TIBC reduces, inverse. Ferritin reduces, TIBC increases, inverse, right? So this is for across the disease, the iron profiles correlation, right? Now let's take IDA. It's not difficult for anyone to know that in IDA, iron will be reduced. That's normal. T-sat is reduced. Ferritin is the most sensitive test, storage form, reduced. TIBC will be increased. Simple. Remember the correlation. You will never be required to memorize iron profile. Okay. Let's go with one more guy, AOCD. Anemia of chronic disease. I want to start with this person. Put a star here because ferritin is an acute phase reactant, right? So in chronic inflammation, ferritin will be more because it's an acute phase reactant. So because of that, TIBC will be less. Because of ferritin being more, my freely available iron is less. That makes my T-sat more. Done? So I put a star mark because you start with that. I don't know where to start with. But for IDA, I know where to start with. It's iron deficiency. Iron is less. But anemia of chronic disease, we start here because it's an acute phase reactant. We know that we use during COVID, we use during every inflammatory disorder. So in chronic inflammatory state, it will by default be elevated, right? Perfect. It's a correlation which will help us to identify for most of the cases, fine? Diagnosis. What's the classical diagnosis? You guys know that. That's a classical hypersegmented neutrophil. Hypersegmented neutrophil, either one neutrophil, at least one neutrophil more than 6 lobes, and the percentage of 5 lobes differs. Some books say 3% or some books say 5% of more than 5 neutrophils. We call it hypersegmented. More than 5 lobes, we call it hypersegmented. Or even a single neutrophil with 6 or more lobes, we call it hypersegmented. See, the 3 is generally for an Indian standard, 5 is generally for a foreign standard, but it's fine, whatever it is. Do remember, anything more lobes, I think of a hypersegmented neutrophil. By default, like Gaurav said, I'm going to think of megaloblastic anemia, right? Megaloblastic anemia is the diagnosis. And one important thing which has been asked before in INI-CET, tell me what's the answer. A patient has an B12 deficiency. Okay. How will you treat the patient? Only B12 or both B12 and folate? Everyone online, do comment on this. This is an INI-CET question. It's important because 10 years back, I was doing it differently. They understood about the disease and now they are doing it differently. Treat with, in case of B12 deficiency, treat with only B12. If we give folate also, that was the older way of treatment. No, that's the older way of treatment. Why both? Only B12. If you give both folate and B12, that was when I was an intern, I was giving both folate and B12. Things change. The only thing in medicine is it is constantly changing. If you give both folate and B12, it will worsen neurological deficit. Anemia will improve. People will superficially say, everything improved, but it will worsen neurological symptom. Because of that, I should not give both. I should give only B12. Do remember them. It's not about INI-CET. It's about the way we manage patients. Managing patient changes, science changes, unlearn and relearn, please. Diagnosis. What's the diagnosis? Whatever comes to your mind, what's the diagnosis? It's simple. It's a bone marrow biopsy. Bone marrow biopsy with more and more of fat in the bone marrow. You think of aplastic anemia. Clear is nothing but fat, right? Aplastic anemia is not anemia. It is pancytopenia, right? So I don't have anything there. You'll have pancytopenia, right? And you can have inherited causes, acquired causes, multiple things. And one favorite question for every Viva places, bone marrow aspirated lava, dry tap here. Because I have nothing, I won't have anything. That's why we do a bone marrow biopsy where everything will be replaced by fat, right? Perfect. Okay, fine. So we'll go to WBCs. I'm going to say a few key important clues for WBC disorder. See, leukemia and lymphoma, unfortunately, does not have very classical clinical clues. There are few places, but generally no. For MCQ, I do have some clues, but clinically, it's lymphadenopathy for lymphoma. Leukemia, clinically, cytopenias. That's how predominantly it is, right? But there are a few clue points in a MCQ which can tell me, okay, most probably this could be the diagnosis, most probably. But ultimately, diagnosed based on microscopy, diagnosed based on markers only in for every leukemia and lymphoma, be it an MCQ or in a real life, right? Clue points for ALL, it's not all, it's ALL actually, okay? Child with lymphadenopathy. There's no leukemia which happens in child with lymphadenopathy. Child lymphadenopathy, it's ALL. Blast will be there, which will be lymphoid blast undoubtedly. There are only two lesions, two malignancies in WBC which can happen predominantly in children. One is child with lymphadenopathy. Second is child with swelling here. Can anyone tell me what's the diagnosis? That's a classical diagnosis, right? There are only two things which can happen in children. Child with jaw swelling. Diagnosis? I'm not even telling the ethnicity here. You know the answer, it is Burkitt's lymphoma. Rest everything happens in adolescents or adults. Nothing happens in children. Children, one leukemia, one lymphoma. Rest everything for an undergraduate level happens in adults or adolescents only. Do remember that, right? AML M3 or your APML is the only leukemia which can present with DIC. No other leukemia can present with DIC. Only leukemia can present with DIC is AML M3 by default, right? AML M4 M5. This is one leukemia which generally presents with extramedullary blast. Okay, extramedullary blast. What do I mean by extramedullary blast? I have blast in your behind the eye, proptosis. I can have blast in the skin, leukemia cutis. I can blast in the gums, gum hyperplasia, right? Gum hypertrophy. These are classical for chloroma. Okay, extramedullary blast is chloroma, where I can see in the skin, leukemia cutis. I can see in the gums, gum hypertrophy, gum hyperplasia. I can see in the retroorbital space, proptosis. Again, need not memorize. Medicine is beautiful when you understand. These are the only two, M4 and M5 are the two leukemias. I have monocytic component. Monocytic, myelomonocytic. Monocyte is, can go to tissue, become macrophage. That's why monocytic leukemia can go to tissue. Neutrophil does not go to tissue. Eosinophil does not go to tissue. It goes only when there's inflammation. But even a normal monocyte can go to a tissue. That's why I can go to skin, I can go to gums, I can go to proptosis. Classical for M4, M5. We'll have hepatosplenomegaly. Classical for M4, M5. Right? M7 will have myelofibrosis. Very rare. This also might be seen in children. But with Downs. Downs myelofibrosis, think of M4, M5, right? There are few classical clues. The history itself, I can say, okay, most likely it could be this. Fine. Okay. By default, you know that. You know for a fact that the exception to crisis, right? When do you call it an acute leukemia? It's not based on age. Acute leukemia is more than or equal to 20% blast. Fine. This exception to blast crisis, whatever we already know, right? We have 3 translocations where it's an exception to blast crisis. Actually, as per the current WHO, it's not 3. Almost everything is in. If you see this genetics, it's an exception only. We have changed it a lot, but for undergraduate, we're not still changing. Exceptions, please look for these 3, at least 821, inversion 16, or translocation 1616, and translocation 1517. At least these 3 does not require blast. 100%, 20% to the roof. There's no 30% at all. 30% was changed in 2004. If someone is still teaching you 30%, they are not seen biopsies after 2004. Nelson still calls it 30%. Nelson is a pediatric books, not a pathology book. Same with Harrison. It's only 20% everywhere. Fine. ALL, AML, everything. Okay. These are older ones, but still will stick to this. PMLRR, run here, like whatever Gaurav said, all the classical mutations. Fine. Okay. So now there are 2 blasts. The first thing, how do I call it a blast? 2 to 3 times more than the size of RBC, it's a blast. It's an immature cell. You see this guy, or rod, right? Or rod is classical for or rod or granules. It's classical for myeloid blast or an AML. Here, no or rods, no granules. That is enough for me to call it lymphoid blast. But you won't accept that there is granules is present. Some will say it's present, some will say it's not present, right? That's why we have markers. We have cytochemistry markers, we have CD markers. Both of them are there in case of a leukemia, right? We'll start with everything. PAS. The pattern of positivity is very important. If the question says dot-like positivity or block-like positivity for PAS, it is ALL, lymphoid blast. The question says cytoplasmic blush-like positivity. It is AML M6, not every AML, AML M6. It's a cytoplasmic blush-like positivity. Like a dot, ALL, right? MPO, SBB, both are for myeloid blast. The best is MPO. MPO by default is the best. SBB is obviously not great. Is the best for myeloid lineage. Okay. To tell it's a leukemia, it has to come from stem cell. Okay, CD34 is a stem cell marker. CD34 is positive in every leukemia except one. Exceptions are always MCQs. Except APML. APML or AMLM3 does not come from stem cell. Acute promyelocytic leukemia. It comes from promyelocyte, not a stem cell. Classical important clue, right? Except APML, everything will be 34 positive, right? There are a few classical CD markers. Let you guys tell what's the answer. Where do you see CD3 positivity? And one more thing I'll add here, a general statement. TDT, which is positive, I think of a lymphoid leukemia. Okay. Where do you see CD3? Anyone? CD3? Classically, you see them in? You know the answer. You're going to see them in T cell. 20? B cell, B lymphoblast. 1464 are classical marker for monocytic lineage. In addition to monocyte, I am adding one more marker here called as NSC. Non-specific esterase, right? It's non-specific esterase. That's also positive in case of your monocytic lineage. 1333 for myeloid. The biggest number, 4161, very high numbers, right? Both are biggest cell, megakaryocytic. Okay. So these are markers. Again, the last go. I'm not including every marker here. One marker or two markers for one lineage for me to diagnose, that's enough for me. So AML M7 will have, that's megakaryocytic. AML will have 34 positivity. It's a blast. Maybe myeloid positive, 41 positive. I called it megakaryocytic leukemia. As simple as that. Fine. Perfect. Diagnosis. Most loved image. Very stupid way of remembering that it's also there. We have removed the name from every medical textbook, but still entrance preparation of NEET PG in India alone has that name. And we call it an garden party appearance or an collegical appearance. The collegical is removed long back, right? I am not going to write it, but I'm sure you know that garden party collegical is seen classically here, which is classical for CML. You'll have leukocytosis and shift to left, where I have blast, myelocyte, metamyelocyte, everything there. That's a classical finding for CML, right? Few more important clues for CML. CML is seen in elderly. Elderly, massively enlarged spleen. The moment you see this in the clinical history, do not jump for CML. Very important. If it's leukocytosis, then I think of CML. If it's pancytopenia, what's the first diagnosis? Elderly, massive splenomegaly, pancytopenia. It's not CML. I think of hairy cell leukemia. Okay? It's very important for you to differentiate both, right? One is leukocytosis, one is pancytopenia. Both are clinically same. Elderly, massive splenomegaly, right? Hairy cell leukemia. In addition to that, there might be history of Mycobacterium tuberculosis or an atypical Mycobacterium infection. Because hairy cell leukemia, in addition to this, also will have, in addition to pancytopenia, also will have monocytopenia. Monocytes will be very, very less. Classical. Hairy cell leukemia will be positive for a marker called as TRAP positive. And one more classical marker is annexin. Annexin positive is for hairy cell leukemias. Fine. Okay. How do you differentiate CML versus leukemioid reaction? Because leukemioid reaction also will have the same shift to left, right? Though it is not useful in real life, for a theoretical purpose, CML versus leukemioid. I don't know why still people keep asking this. Leukemioid is sepsis. Do you think a post-MBBS student will struggle to identify sepsis? Not at all. I have trust in my MBBS students, right? Sepsis is sepsis. CML is CML. Why do they have differential diagnosis? I don't know. But they had long back, right? So still they keep asking this lab score. Okay. Lab score will be almost close to 0 or negative in case of CML. Lab score will be increased in case of leukemioid reaction. Theoretically, yes, differential diagnosis. Practically, not at all a differential diagnosis, right? Okay. Now, last but not the least, investigation of choice for CML. I'll give you options. You tell me. Bone marrow aspirate, IHC, fish. What will be the investigation choice for CML? Bone marrow aspirate, IHC, or fish? What do you think will be the investigation choice? It is classical genetics. It's fish. Bone marrow aspirate is not required in CML. IHC is not done in CML. It is only fish. If fish is not there, yes, less cheaper alternative, less specific alternative of karyotyping. It's only genetic diagnosis. I don't do a bone marrow aspirate. You don't require a immunohistochemistry for your CML diagnosis. Fine, perfect. Diagnosis. Classical history will be adult with lymphadenopathy. Okay, that's a classical history for this disease. Adult with lymphadenopathy. Can anyone tell me what's the diagnosis? Lymphocytosis are in excess. I have destroyed cells which are called as smut cells. This patient also will have a classical autoimmune hemolytic anemia as a classical diagnosis of CLL bar SLL, right? So adult with lymphadenopathy, generalized lymphadenopathy, fine, with autoimmune hemolytic anemia. See, AIHA is something which is very, very commonly associated with CLL. Do remember them. And the classical smut cell. In microscopy, I'll have lymphocytosis. These are not normal lymphocytes. These are abnormal neoplastic lymphocytes. These will have a soccer ball chromatin. That's a famous chromatin named in CLL. Soccer ball like chromatin. And obviously the smut cells. CLL is diagnosed on flow cytometry. Though smut cell gives me a clue, but I need to do a flow cytometry to confirm CLL, right? Okay. Evans syndrome is your CLL plus ITP plus autoimmune hemolytic anemia is Evans syndrome, your right supposition. Fine. So there are multiple markers for CLL. They are 5 positive, they are 23 positive tumors. But one marker in flow cytometry especially is your CD200. Do remember them. CD200 positive, and by default they are 5 positive. They are 23 positive as well. Okay, that's about CLL. Fine. There is a classification name in CLL. This has been asked before in a AIMS exam. Rai and Binet classification is a classification with CLL. Rai is an Indian. I think he did a postgraduate or somewhere in AIMS. So it was asked long back, quite some times. Do remember them. Rai and Binet classification is a classification where you saw CLL. Yeah, if you want the convent girl, let's keep the convent girl appearance or a uniform looking lymphocytes. That's a classical thing for a CLL. Fine. Okay, perfect. What's this diagnosis? It's a lymph node biopsy. Tell me the diagnosis. That's a classical case of a follicular lymphoma. Multiple follicles in a lymph node has to be a follicular lymphoma. There's no doubt in that. Okay. Follicular lymphoma is a germinal center origin tumor. You need to know the translocation. Translocation is diagnostic here. 14, 18 translocation. See, everywhere 14 is common, right? 18 is classically mutated here, right? So what do you have in chromosome 18? You have your BCL2. More BCL2, they don't die. Apoptosis does not happen, right? That's the reason it keeps on accumulating. So it's a very, 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 very slow growing lymphoma. Okay. So Vijit, I'm not denying that, Gaurav, I'm not denying that you will have CD10 positive here. But I want you to remember only one thing. CD10 is positive in any tumor which comes from germinal center origin. But to remember the marker, the best marker, always go to the diagnostic translocation. 18 and BCL2 is a diagnostic translocation, right? So I also want the marker also to be the same. For a marker, remember BCL2. BCL2 is the best marker here. I'm not denying 10 will be positive, BCL6 will be positive, but that will be positive in every germinal center tumor because CD10 is a germinal center marker, right? But BCL2 is for follicular lymphoma. So remember this diagnostic classification. That will help us remember the rest. Same for others. Let's say mantle. My senior said call mantle like this, right? Write mantle like this. So its translocation 11, 14. 14 is common, na? 11. Mantle looks like 11, right? 11th chromosome has your cyclin D1. So what's the marker of mantle? Cyclin D1. And this can have classically presents as polypus incident lymphomatoid polyposis, okay, which is classical for mantle cell lymphoma, which can present as polyps in the intestine. Fine. And the IHC for me here is same cyclin D1. That's the most important IHC here. Or BCL1. Perfect. That's the most important IHC for me, right? But AIMS did ask one question. Cyclin D1 negative mantle. What's the marker? What's the marker for cyclin D1 negative mantle? Let's see if you guys can answer. See, these type of questions keeps coming once often in AIMS exam. A question which is difficult even for a postgraduate. That's to show off or to judge you if you are taking undue risk. Because in undergraduate, there's no way they will know what will be positive in cyclin D1 negative mantle. Now you know because of PYT. Before that, no one even must have heard of SOX11. Like that, every exam will have bouncers. A smart person will not touch the bouncer because there's more chance of having negative markings. But the same question repeats again, I want you to know. Actually, there's SOX11 negative mantle also there. Next time if it comes, don't touch because the probability of you knowing is very, very, very less. And you need not know it. Right? You're basic of the most earliest part of your medical career. You'll know it when you come to that place. Fine. What's the appearance? No one will ever forget this appearance, right? Bucket. The same senior who told me mantle also told one more thing. Bucket lymphoma. Easy way to remember, na? Translocation 814. Translocation 28. Translocation 822. 8 is the most important there. Everywhere it's 8, right? So because chromosome 8 has a guy called as CMYC. That's a proton collagen is mutated. That's what is getting translocated in Burkitt's lymphoma. Burkitt's most of the time is EBV positive. Like endemic Burkitt is 100% EBV positive. Even sporadic Burkitts are also EBV positive. It's not that only endemic, but endemic is 100% EBV positive. That's a classical difference between endemic and sporadic. Microscopy have this appearance of starry sky. Okay. Burkitt's, because of its Ki67 being close to 100%, very fast dividing, they can undergo mets to bone marrow. The moment they go to bone marrow, you have a blast appearance. We call it Burkitt's blast. Okay. So what we have is, we have a sky blue cytoplasm. And not just cytoplasm, you'll also have vacuoles in the cytoplasm. That's diagnostic of Burkitt's blast. Vacuoles and a bluish cytoplasm is for Burkitt's blast. Okay. One unique thing about Burkitt's blast, can I say Burkitt's is a lymphoma blast? Lymphoid blast? It's a lymphoma, has to be a lymphoid, not myeloid, right? Burkitt's is a L3 type of lymphoid blast. In older classifications, we had L1, L2, L3. It's a lymphoid blast. A lymphoid blast is PAS negative and SBB positive. Again, unique. Every lymphoid blast is PAS positive, but Burkitt's blast is PAS negative and SBB positive. Actually, SBB is a myeloid marker, right? That's unique about Burkitt's blast, so do remember them. Fine. Okay. Few more classical images. Can anyone tell me what this is? I'll kind of give you a clue. This, though it might not be the right image, the right images look like this. The nucleus looks like this. What's the diagnosis? That's a classical hallmark cell or an embryo-shaped cell. It's diagnostic for anaplastic large cell lymphoma translocation 2-5, where you have translocation between ALK gene, anaplastic lymphoma kinase gene, and NPM1 gene. That's a translocation. Anaplastic large cell lymphomas, one of the recent association is it is seen in patients who have silicone breast implant, especially in axial lymph node. The breast implant increase the risk of anaplastic large cell lymphoma. Do remember that. A recent advancements you might be asked. IHC, like I said, always the mutation. They are ALK positive tumors and also they are CD30 positive. Okay, anaplastic is a T cell lymphoma. It's not a B cell lymphoma. Fine. Few important characteristics of anaplastic large cell lymphoma, right? The skin biopsy. This is your epidermis, the reti ridges. I'm drawing them. And someone is going here. What do we call this? Some cells are going in between the layers. That's a diagnosis of this tumor. What do we call that? What do we call that? That's a classical, very classical epidermotrophism. The moment the neoplastic WBCs goes to the epidermis, we call it epidermotrophism, seen in a CD4 positive tumor. Anyone, what's the diagnosis? CD4 positive lymphoma presenting in the skin, looking like a fungal infection. So we used to call them mycosis fungoides because it looked like a fungal infection. It's not a fungal infection. It is undoubtedly a cutaneous T cell lymphoma, classical epidermotrophism. And I'm sure you must have known this also. Mycosis fungoides, when it's systemic throughout the body into the blood, we use the term Séchary syndrome, right? And these are the Séchary cells. Okay, these are Séchary cells or Séchary-Lutzner cells, right? This is full-blown mycosis fungoides where you have a very irregular nuclear membrane. For the first person who saw, it looked like brain, so I call it an cerebriform appearance. Okay, it's the same of mycosis fungoides but seen in systemic cases, right? Full-blown systemic case of mycosis fungoides where it involves your bone marrows, you involves your lymph node, involves your blood circulation. Fine. Okay, this is spotter. They're not asked till now. They ask in this exam, it might help you. A classical clover leaf shaped cells. It looks like a clover leaf, right? Looks like that. Clover leaf is a leaf what you must use in the WhatsApp emojis, the green one with 4 petals, like, right? The clover leaf. Fine. Classical clover leaf shaped cells. This is diagnostic of an adult T cell leukemia lymphomas. Can anyone tell me the virus which is involved in adult T cell leukemia lymphomas? Yeah? HTLV1. Okay, HTLV1 is a only oncogenic RNA virus. Most of the viruses are DNA virus, right? One of the oncogenic virus, RNA virus, which has a gene which causes the leukemia is HTLV1. Very aggressive tumor, common more in the Japanese area, Caribbean area, not so common elsewhere, right? But HTLV1 causes your adult T cell leukemia lymphomas. Fine. Okay. Spotter, diagnosis. And I'll ask you a follow-up question. You have to tell that follow-up question also. It's a classical RSL, Hodgkin's lymphoma, right? So it's a classical outside cell. What is the other thing which also has an outside appearance? Other disease which also has an outside appearance. Which is CMV. How do you differentiate CMV from a RSL? How do you differentiate CMV from a RSL? You look at the nucleoli, right? Like you can see this image, RSL have a classical eosinophilic nucleoli. Okay, CMV is a basophilic inclusion. If I have only the image, this is the way to differentiate them, right? If I have the history, very easy. CMV is not going to cause lymphadenopathy, right? It will cause chorioretinitis, it might cause hepatitis, might cause few other infection, right? But if it's the image alone, eosinophilic, basophilic inclusion can easily help us, right? Eyes are blue, that's a good way to remember, right? In CMV, it's a ovular nucleus, it will be blue in color, fine? This is a classical RSL. This is a very, very classical RSL diagnostic, right? So if we look at RSL, we have nodular sclerosis. We have your mixed cellularity. We have lymphocyte rich. And we have lymphocyte depleted. Fine. So there are 4 variants of classical Hodgkin's lymphoma. All of them will have classical RSL, not denying that. In addition to that, they might have few other cells. And all these RSLs are positive for same marker which you already know. All the classical Hodgkin's lymphoma RSLs are positive for 15 positive, 30 positive, PAX5 will be weakly positive. This is classical for every classical Hodgkin's lymphomas RSL. Okay. Yes, Chaitanya might have a transplant history, might have an immunocompromised state. History will be definitely different from case of an Hodgkin's lymphoma. There's no doubt in that. Fine. Okay. So nodular sclerosis. See, if you look at commonality, the most common thing keeps on changing. This is the most common in the world. Actually, it's most common in India also. Few books are not updated, but still it's the most common in India as per the Indian oncological data is the most common type, right? This is most common in developing nations. Good thing. At least here, India has become a developed country, right? Like African areas, mixed cellularity is more common, right? Nodular sclerosis is actually EBV negative. Mixed cellularity is actually EBV positive. This also is EBV positive. This guy is both EBV positive as well as HIV positive. Lymphocyte depleted. That's why lymphocytes are getting depleted, right? Because HIV virus can destroy the lymphocytes. That's why we call it a lymphocyte depleted Hodgkin's lymphoma. Fine. Okay. So here, nodular sclerosis microscopy, I do have the nodules of sclerosis, right? It has sclerotic bands of collagen. That's one by default. Plus, you'll have the lacunar variant of an RSL. Where you have RSL with the clear cytoplasm. Mixed cellularity, you'll have a very mixed background population. Both mixed population of RSL, you'll have mononuclear RSL that was called as Hodgkin cell before. Not binuclear double shape, you'll have mononuclear RSL, also mixed background popularity cells, right? Here, I'll have the classical RSL plus background here will be purely lymphocytes. It will not have eosinophils, it will not have macrophages much, purely lymphocytic background. That's why we call it lymphocyte-rich Hodgkin's lymphoma, right? Lymphocyte-depleted Hodgkin's lymphoma will have classical RSLs plus you have variant called as a reticular or mummified variant of RSLs. Where the RSL looks like a smudged nuclei, we'll have pleomorphic RSL. Okay? And obviously because of the HIV nature, it has less lymphocytes in the background. That's why the name lymphocyte depleted. When you look at the prognosis, this has the best amongst Hodgkin's lymphoma. If we look at the prognosis, it actually declines like it's better, not the best, it's good, poor, worst. Okay, the prognosis is always like this. The best is actually NLPHL. This is the decreasing out of the prognosis. Best is by default NLPHL. Then I have the rest of them. Fine. Lymphocyte depleted is the least common variant. It's the one with worst prognosis. Okay. Fine. So this is the NLPHL. So NLPHL is a unique variant of Hodgkin's lymphoma for multiple reasons. One is this appearance. How does it look like? It's actually a very irregular nuclear membrane. So for the person who first saw, looked like a popcorn. If you can imagine like a popcorn, it looked like a popcorn. But unfortunately, if I remove this drawing, you won't even identify it's an RSL, right? That's a problem with histopathology and undergraduate life, right? So this is how a popcorn shaped cell looks like, a irregular nuclear membrane, right? It's seen most commonly in young individual and they rarely spread. They'll be stuck to one lymph node, that's all. Cervical, it will stay in cervical. Won't even go to lower cervical or supraclavicular. Stays here, stays there always. That's why the best prognosis, not going far, right? Here, you'll have the popcorn variant of RSL There's one more name for it, LNH variant. That's the ideal name. Lymphohistiocytic variant of RSL. That's the right name, right? So IHC, if you look at it, you have CD20 positivity, you have 45 positivity, and you have PAX5 strong. Okay, fine. Because of the 20 positivity, I can add rituximab as targeted therapy. And because of the rare spread, the stage always, most of them stay in stage 1. That's the reason has a very, very good prognosis, right? It's very good prognosis because of the positivity and also because of the nature of the tumor, right? I'm not a person who has to be talk about chemo, but ABVD regimen has been the regimen which has been used for Hodgkin's lymphomas. I can add R to it. R for rituximab. I can add rituximab for an NL-PHL. That's a general regimen which has been done for Hodgkin's lymphoma cases. Fine. Perfect. One slide we're going to quickly see most required things for Hodgkin's lymphoma. Okay. Done. Now, we've done quite a few things with respect to RBCs and WBCs, right? Can you take a 5-minute break and then start systemic pathology? Yes, no, maybe. I'll just switch off the camera and the mic. 5 more minutes. We'll start back by 12:54, 55. Okay, just 5 minutes. We'll come back. Thank you. Hey guys, welcome back. Are you here? Hello, hello, hello. Hi Subjit, hi Gaurav, hi Chaitanya. Let's start. So we have completed a little bit of hematology and a little bit of the general understanding of stains, IHC, and also your basic fixatives and other procedures, right? So I have very few topics in systemic pathology which I want to focus on. One is your postmortem appearance in MI, a little bit about glomerulonephritis, a little about GI pathology, and also we'll quickly go through very important high yielding topics of general pathology, right? So we're ready? Let's start. Okay, so this is the postmortem appearance in MI. Though the real application of postmortem appearance in MI is almost nil, but on and off, one by one after other exam, this keeps coming, right? So postmortem findings or the timeline of infarct is something which is very crucial for us, right? So if I see a fiber which is like this, a very wavy fiber, that's between half an hour to 4 hours after the infarct. Initial 0 to half an hour after the infarct, there'll be no light microscopic finding at all. You won't see any light microscopic finding in 0 to half an hour post infarct, right? But for half an hour to 4 hour post infarct, the only finding you will see is waviness of fibers. Okay, it said that few books say that the waviness of fibers is due to the excess of calcium causing hypercontractility of the fibers. Few books say that it's the buckling effect of the dead areas because the normal areas surrounding them pull them and they buckle because of that. What else said and then I'm having a wavy fiber half an hour to 4 hour after infarct, right? 4 to 24 hours after infarct, what you will see is you will see here only necrosis, nothing else. Not even neutrophilic infiltrate. Only necrosis in 4 to 24 hours post infarct till 1 day. Only necrosis. So in microscopy, I'll see only pink color fibers. You won't see any infiltrating cells whatsoever. Right? I have only dead tissue, pure pink coagulated necrosis. Right? After that, 1 to 3 days. So in 1 to 3 days, I have two findings here. One, yes, if you see this, these are fibers, right? Can you see any nucleus in these fibers? No. These are all dead fibers, right? There's no nucleus, right? These are definitely necrotic fibers or the necrotic areas because they have no nucleus. But if you see carefully, in between the necrotic fibers, what I see is I see classical neutrophilics, right? Neutrophilic infiltrate. So 1 to 3 days, what I see is I see both necrosis plus I'll see good amount of neutrophilic infiltrate. That is classical for 1 to 3 days. Actually, Robbins says that in the first day, you'll see more necrosis, less neutrophils, incoming neutrophils. And the last day, I'll have more neutrophils and less necrosis. Actually, I cannot tell that. It's a dynamic change, right? But in a biopsy, it's a screenshot. I can see two findings, necrosis, neutrophils. I don't know whether this neutrophil is incoming or outgoing. Not be able to say. So it's a hallmark of 1 to 3 days, right? After neutrophil comes macrophage. That's all. Whenever you see cells with clear cytoplasm, clear is foam cells, na? The clear cytoplasm is a clue. Clear cytoplasm is equivalent to macrophage. Between 4 to 7 days, what I see is only macrophages in the biopsy. Listen carefully. This is a very important thing for almost every wound which heals by secondary intention, like MI, like a midline laparotomy scar. Right after a laparotomy, you do a scar. That's also like injury, secondary intention. During secondary intention, around the 4th to 7th day or 5th to 8th day, the tissue will be very weak, extremely weak. That's why this is because only macrophage, no necrotic tissue, no healing tissue, right? This is the weakest point of the wound healing. That's why there's a place you can have rupture of myocardium is very common here. That's why, like I said, in a midline laparotomy scar, if you've read in surgery, burst abdomen. Burst abdomen is a very classical finding which is seen around 5th to 8th day because wound healing at that time will be very weak, right? Please kindly correlate because around this day, when I see only macrophage in the biopsy, that's the weakest point of the entire wound. So there's a possibility of the rupture to happen. Fine, perfect. After that, wound will start to heal 4 to 17 days. Some books say 7 to 10 days. Some books say 7 to 14 days. We'll extend it 7 to 14 days. I'll have granulation tissue. Okay. You'll have granulation tissue between 7 to 14 days. What is in granulation tissues? You will see vessels plus you will see collagen, and the collagen will be type 3 collagen. Okay, these are actually the collagen fibers. Can anyone tell me what's the stain for collagen fibers? We have read multiple stains in the start, but we didn't read collagen fiber stain. What's the stain for collagen fibers? What's stain for collagen fibers? Stain is Mason's trichrome. Okay, Mason's trichrome is stain for collagen fibers. Trichrome, 3 colors. In that, collagen will be bluish in color. Okay, that's a classical finding for Mason's trichrome. Fine, done. Then anything beyond 14 days. The moment you have a scar tissue, if it's 5 years or 6 years or 10 years, I'll have only scar, right? Anything beyond 14 days, it'll be only collagen scar, right? That's what you'll see in any time beyond 14 days in case of an myocardial infarction, right? Perfect, classical. So these are the timelines for MI. Different timelines, postmortem findings, what you see in MI, right? Now we'll just quickly go through few classical microscopic findings in your kidney pathology, glomerulonephritis, right? This glomerulus, if you see, the entire membrane is thick. Okay, you have a very thick capillary basement membrane. The entire capillary is very, very thick. Thick like a membrane, so we call it membranous glomerulonephritis, that's all. Okay, in membranous glomerulonephritis, it's a nephrotic syndrome. The pathogenesis is antibodies against a classical receptor called as PLA2R. Do remember, FDA has approved PLA2R as a standalone blood test to diagnose membranous glomerulonephritis. I don't want a biopsy anymore, right? In microscopy, what I'll have is, I'll have a thick capillary wall. See, one important thing here is, the capillary wall being thick, right? It's seen in 2 diseases. When I have thick capillary wall microscopy, 3, let's add one more, right? One, I'll think of an MGN. Second, I'll think of a Goodpasture syndrome. That also have thick capillary wall. Third, I'll think of a diabetes mellitus. So how do I differentiate them? Immunofluorescence, that's all. If in immunofluorescence, I see IgG granular, it is MGN. If I see IgG linear, it is Goodpasture. No immunofluorescence, because in diabetes, is a true basement membrane thickening. It is not immunoglobulin deposit, right? There will be no immunofluorescence. I think of a diabetes. Perfect. And with electron microscopy, here it will be your subepithelial deposit. No deposit, right? Classical, right? Since we are in DM, tell me one classical microscopic finding for diabetic nephropathy. That's a nodular lesion. KW lesion or a nodular glomerulosclerosis, very, very classical, right? And also we have one more lesion called as an Armani-Epstein lesion. Armani-Epstein lesion is more of a finding in proximal convoluted tubule, where you'll have glycogen deposit. You'll have glycogen deposit here, proximal convoluted tubule, classical for an Armani-Epstein lesion. Fine. Okay. Perfect. Done. Let's go to next image. When you have more cells inside the glomerulus, normally glomerulus will be empty. If you look here, actually I have lots and lots of WBCs inside, right? We call them endocapillary hypercellularity, diagnostic of PSGN. Actually, PSGN is not diagnosed by biopsy. It's by history only, right? If you have a history of an URI or a skin infection, right? Post, there's a lag time. There's a minimum of 1 to 3 week lag time. I'm just giving 2 weeks. You have classical hematuria, because a classical case of a nephritic syndrome. That is PSGN or PIGN. Same URI, it's a very important differential diagnosis. Second day, you have hematuria. Can anyone tell me what's the diagnosis? Same URI, but no lag time. Hematuria, I think of an IgA nephropathy, not a PSGN. That's very, very, very important. Clinically, there's a very close differential diagnosis. You have to know about that. Fine. Okay. If you miss the diagnosis, you might miss everything. It's very important. Lag time is must in case of PSGN. Lag time will not be there in case of IgA nephropathy. Both can be after URI. Both can be hematuria. Books say IgA nephropathy is microscopic hematuria. Both of them are microscopic hematuria only, right? Doesn't matter. It's hematuria, that's all. If I see that, I think of an IgA nephropathy, there's no lag time. Very, very important for us, right? And can I differentiate these two in any other way? Obviously, microscopy can easily differentiate. Microscopy for PSGN, I'll have more cells inside capillary. That's why endocapillary hypercellularity. In IgA also I'll have more cells, but outside capillary. Where? In the mesangium. I'll have mesangial hypercellularity. Okay. Can I differentiate via immunofluorescence? Obviously I can. Here I'll have granular deposits of IgG C3 in the capillaries. Here I'll have IgA deposit. Where? Not in the capillaries, in the mesangium. IgA present, IgA nephropathy. As simple as that. Right? Electron microscopy. Classical finding is sub-epithelial hump-like lesion. Very, very classical for PSGN. But here you'll have, again here you'll have mesangial deposit. Classical mesangial, everything goes to mesangium in case of an IgA nephropathy. Can anyone tell me one other name for IgA nephropathy? IgA nephropathy has actually one more name. It's also called as Berger's disease, right? Berger's disease, IgA nephropathy. I'll ask one more question. Let's see how many of you answer. Same problem, IgA nephropathy plus the IgA deposits are also in my skin, also in my GIT, also in the kidney. What disease it is? If IgA nephropathy becomes systemic, what do I call it? Anyone? Comment that. I'll answer soon. Fine. There are two diseases in kidney which can be systemic. If it's an only kidney involvement, I call it anti-GBM glomerulonephritis. If it's systemic, I call it Goodpasture syndrome. If it's only kidney involvement, I call it IgA nephropathy. If it's systemic, we call it Hematopathology purpura, right? Do remember these two. It's very, very important. If it's kidney alone or if it's systemic. Two diseases can have it. Kidney alone, I call it anti-GBM glomerulonephritis. Here we call it Goodpasture syndrome. Okay, perfect. Not dermatitis suppurative, you're right. HSP is right? So here kidney alone, I call it an IgA nephropathy or Berger's disease. Here I call it Henoch-Schönlein purpura. Okay, the systemic involvement and Henoch-Schönlein purpura. Fine. So this is what I see in IgA nephropathy. A classical expansion of the mesangium. Mesangium is a space between the capillary. Okay. So mesangial widening is also seen in two diseases. This is how mesangial widening looks like, right? I see in both IgA nephropathy and also in the MPGN type 2. The recent name for this is C3 glomerulonephritis. How do I differentiate? Both will have URI, both will have hematuria, both will be no lag time. The way to differentiate is immunofluorescence. Here, I'll have IgA positivity in immunofluorescence. C3 also will be positive here, but here there'll be only C3 positive in immunofluorescence, no IgA. When there's no IgA, it's not IgA nephropathy, right? So mesangial widening plus C3 only, C3 glomerulonephritis or MPGN type 2, not an IgA nephropathy, remember that, fine? Okay, and obviously here, electron microscopy will be there in the mesangium. Here electron microscopy will be intramembranous. So we call them a dense deposit disease inside the membrane, intramembranous or a dense deposit disease. Fine. Classical for your MPGN type 2. Fine. Okay. Perfect. These are immunofluorescence image, right? So let's mark it 1. Let's mark it 2. Everyone here, tell me which is linear, 1 or 2. Which is linear, 1 or 2? You know the answer. Something which is very, very continuous is linear. This is linear. Remember this image forever because there's only one disease in the entire kidney which can be linear. No other disease can be linear in kidney except for anti-GBM glomerulonephritis or Goodpasture syndrome. That's the only thing which can be linear. Rest everything in your kidney will be granular. Okay, there's a granular positivity. Everything will be granular and linear is only your Goodpasture syndrome or your anti-GBM glomerulonephritis, right? Perfect. Okay, done. So crescent. That's a beautiful crescent. There's an image from Robbins where you have the entire kidney being destroyed, a crescentic glomerulonephritis, right? So crescent, RPGN, history will be very classical. A creatinine of 2 milligram percentage, becoming like 8 or 9 milligram percentage within a span of 24 to 48 hours. That is important. If they progress in 2 weeks, it is not rapid. The progression should be rapid. That's why I call it rapidly progressive glomerulonephritis. This time is very, very important, right? That's classical for RPGN. Any glomerulonephritis can become RPGN except minimal chain disease, because minimal chain disease will be cured most of the time. They don't complicate. Anything else, your good pasture, your MGN, MPGN, everything can become RPGN because of the pathogenesis. The pathogenesis is classical, which is the rupture of the capillary. Obviously, if the capillary ruptures, glomerulus is nothing but capillary, na? Entire glomerulus is gone. That's why what happens in RPGN is a capillary rupture, that's all, fine? Because of that, I have a crescentic model happening, right? We differentiate RPGN based on IF. Based on immunofluorescence, we classify RPGN into type 1, type 2 and type 3. Type 1 is linear IF. Type 2 is granular and mesangial IF. Type 3 is posse-immune, which is no IF. Okay. So type 1 is classical good pasture, na? Linear, only one is linear. Type 2, rest everything, I'm not writing them. MGN, PSGN, MPGN1, MPGN2, IgA nephropathy, everything will be type 2. Rest everything, except minimal chain disease, it will not happen. Like I said, it's an exception. Type 3 is posse-immune, no immunofluorescence. It's not a kidney-specific disorder. It's a vasculitis, vaginous granulomatosis, microscopic polyangiitis. Okay, that is type 3. Fine. That's based on immunofluorescence. We classify RPGN. And what we see in electron microscopy, this came on the NEET PG exam. Pathogenesis. That's what I see in electron microscopy. I have rupture or breaks in basement membrane. Breaks in basement membrane is something which is classically seen in case of an RPGN in electron microscopy. Fine. Okay, this is classical for your crescentic glomerulonephritis or RPGN, right? Last but not least, I have FSGS. You can see now, half is gone, sclerosed. This is the most common cause of nephrotic syndrome in adults. Classical cause of nephrotic syndrome in adults, right? Most common in children is minimal chain disease by default, right? FSGS will be the microscopic finding for almost any chronic kidney disease, be it diabetes, be it hypertensive, be it SLE, whatever it is, end stage is FSGS by default. It's focal segmental glomerular sclerosis, right? Okay. FSGS has a classification. I want you to remember the classification name, might come in an exam, called as Columbia classification. Okay. It's Columbia classification, a classical finding seen in FSGS. Okay. FSGS, one variant of classification called as collapsing variant of FSGS. This has come in exams before. That's under Columbia classification only, where it is seen in HIV associated patient with mesangiolysis. It's collapsing, no? Everything is gone, and glomerular tuft will undergo necrosis as one of the worst prognosis in case of FSGS. Because of the destruction of the glomerulus, not just that, I have a deadly infection associated also. That's classical for FSGS. Fine. Perfect. Done. Few things to remember regarding FSGS. Okay. Let's go to a little bit of GIT. Okay. Just few more. So GIT, GI cancers is important. You will definitely read GI cancers in correlation with your surgery. Inflammatory bowel disease, something which is very common in both surgery as well as in medicine, right? So in short about inflammatory bowel disease, it's about Crohn's and ulcerative colitis. What happens here is I'm going to have an abnormal T cell response to GIT. That's what's going to happen. So T cell has two different variants. If it's more of Th1, it results in Crohn's disease. If it's more of Th17, it results in ulcerative colitis. Th1 generally forms granulomas. That's why Crohn's have granulomas. Th17 generally forms acute on chronic inflammation. Okay. That's why your ulcerative colitis have acute on chronic inflammation. That's why ulcerative colitis has more chance of having crypt abscess. It's a chronic inflammation, but still I can have accumulation of neutrophils because of the pathogenesis. Okay, that's what happens here. Clinical features, both of them will have altered bowel habits, dysentery with mucus, diarrhea, dysentery with blood and mucus is how clinically it will present. More or less will have very excruciating colicky abdomen pain for both of them, right? But there are few classical gross and microscopic findings. There's a classical cobblestone mucosa. Cobblestone mucosa is because of deep transmural ulcers. And deep transmural ulcers are seen in case of Crohn's disease. It's not seen in case of ulcerative colitis. Very deep transmural ulcers. That's why this looks like cobblestone. Very classical. Fine. This is pseudopolyp. Pseudopolyp is because of continuous superficial ulcers. Continuous broad-based superficial ulcers. That is classically seen in case of ulcerative colitis, not seen in Crohn's disease. Very classical image of pseudopolyps. Actually, if you look, the entire colon is destroyed here. The entire colon is gone. The only place where I see the colon is here. These are not polyp. These are the normal overhanging mucosa. Rest everything, na? It is gone. Here only it's retained. That's a classical pseudopolyp here, fine? This is fat wrapping. Or you must have known there was creeping part of fat. This is a normal image. Normal mesenteric junction. But if you go here, it is gone till this. Generally, mesentery does not go this much. Mesentery will stop with this. It has gone beyond that, right? We call it a creeping part of fat. This is also because of serositis. Nothing but transmural inflammation. Right? Transmural inflammation again seen in Crohn's disease. If serosa can involve, can the entire intestine rupture? Possibilities are now. Crohn's disease still can have fissure, fistula are common in Crohn's disease. Sinuses are common in Crohn's disease because of transmural destruction. Very classical for Crohn's disease. Fine. Okay. A few things which I want you to remember with respect to the inflammatory disorder GAT, right? Let's quickly go to gastric tumors. So gastric tumors, I have two classical gastric tumors. One is your intestinal type gastric cancer. Intestinal type by default is the most common subtype. Intestinal type by default has increase in risk with your chronic H. pylori infection. Your increase in risk with more of smoke food consumption. That's the reason you have more of them in your Japanese population, right? In microscopy, I'll have excess of abnormal glands plus infiltration. That's very, very classical here, right? Okay. Gross, you'll have ulceroproliferative lesion here. The other case, diffuse type gastric cancer. Diffuse type gastric cancer, the pathogen is different. It's mutation. It is CDH1 loss, which is E-cadherin loss. Because of E-cadherin loss, you will not have a mass. Rather, the cells will spread. E-cadherin is cell adhesion molecule, right? It won't adhere, cannot form a mass. It will spread across the stomach. So because of that gross, the cells spread across here. Desmoplasia also will spread across. That's why I have a very, very thick finding. We call this an linitis plastica, like a leather bottle. So we call it leather bottle appearance. Very, very thick like a leather bottle appearance. Classical for your diffuse type of gastric cancer, right? Same microscopy. Microscopy is also very classical. You have cells like this, cells with nucleus in the eccentricity. We call it a Signet ring cells. Again, a classical finding for diffuse gastric cancer. So they can easily spread. They can easily undergo metastasis, right? Classical for diffuse gastric cancer, right? Few important polyps. We'll go to the most important one. This is the most important polyp of the intestine, where you see, can anyone tell me what's the diagnosis? Where you see muscle going between the layers of the glands. Whereas see, muscle between glands. It's like a tree, arborizing like a tree, right? It's like a tree like, which is classical for Peutz-Jeghers syndrome or Peutz-Jeghers polyp. Very, very classical for Peutz-Jeghers syndrome and Peutz-Jeghers polyp, right? Great, Dhruv. It can undergo Krukenberg's metastasis. Krukenberg's goes to the ovary, diffuse type of gastric cancer. You're right. It's Peutz-Jeghers polyp, right? Please remember, STK11 is a mutation. The gene gets mutated. Peutz-Jeghers polyp can be syndromic also. In syndrome, everyone knows that when you have polyp, the first thing which comes to your mind is oral pigmentation, right? The mucocutaneous pigmentation, not denying that, will be classically seen in Peutz-Jeghers polyp, right? The most important thing to this is the history of risk of other cancers. Never forget this. This came in last INICET exam as match the following. Quite a few of your seniors missed it. Peutz-Jeghers polyp has a very, very high incidence of pancreatic cancer, breast cancer also, not just your colonic tumors. There's a very high increase of pancreatic, never forget. It's close to 50 times risk. Also, breast cancer. Breast cancer is not always BRCA syndrome. BRCA is the commonest, right? But Peutz-Jeghers also has an increased risk of breast cancer, has an increased risk of pancreatic cancer. Do remember, this is seen in Peutz-Jeghers syndrome, not in polyp. Okay? And this is the most common location is in jejunum. Fine. Peutz-Jeghers and hematomatous polyp. But the most common hematomatous polyp is this guy. There's a most common hematomatous polyp. So it is seen predominantly in children, in rectum, and that's a name given to it called as a juvenile polyp. Children, right? Children in rectum, juvenile polyp. What I see in microscopy is it's actually an retention cyst, retention polyp. The mucus gets retained in the glands and it swells up like this. Dilated gland with mucin, right? So what I see in microscopy is you see dilated glands with mucin. That's classical for a juvenile polyp, right? Perfect. Gaurav, you're right. If it's a juvenile polyposis syndrome, okay, juvenile polyposis syndrome, JPS juvenile polyposis syndrome, where I have SMAD4 mutation, okay, can have SMAD4 mutation, classical in juvenile polyposis syndrome. I want to add one more thing here. SMAD4 mutation will be involved in TGF beta pathway. Please remember, put a star mark here. Most of the growth factors are proto-oncogene because proto-oncogene helps in the growth. TGF beta is transforming growth factor beta, but this is not a proto-oncogene, it's a tumor suppressor gene. Okay, the name has growth factor, but it's a tumor suppressor gene. Why I want you to remember this is you might end up in making a mistake. It's a growth factor, it's a proto-oncogene. It's not. It's a growth factor. For whom? For fibroblast. It grows fibroblast, reduces every other growth, reduces epithelial growth, right? So it's a tumor suppressor gene. It's not a proto-oncogene, remember that. Fine? Okay. There are two polyps which are must to know. I have two more polyps. One, when I have lots of villi here, right? When there's more than 75% villi, we call it a villous adenoma. Villous adenoma is a bit dangerous. And here, what I have, this is actually a polyp. Something protruding from the mucosa as a polyp. When you have multiple tiny tubules, we have tubular adenoma, right? It's a classical tubular adenoma. Okay. Tubular adenoma is benign. They have a less risk of cancer, less risk of recurrence. Villous adenoma has a very high risk of tumor formation, risk of cancer formation, and also high risk of recurrence. So has to be removed, has to be followed up very carefully, right? Villous adenoma can have invasion. The moment it's invaded, it automatically goes to a cancer. We'll have dysplasia, low grade, high grade, has to be followed up by default. Fine. So these are a few things with respect to your GIT. Okay. I'm going to talk about very few things with respect to general pathology. One, I'm going to talk about amyloid. And last but not least, which I want you to remember before going to the exam is genetic pedigree formation. Because pedigree is something I'll tell you a way of pedigree. If you've listened to me before, you know that pedigree can be solved in 5-10 seconds. There are very standard rules for pedigree. The moment you know that, pedigree solving is not difficult at all. Alternate exams, pedigree do come in an exam. So know how to solve pedigree. The day before the exam, read it, write in the exam, solve the exam correctly, then forget it. Because unless and until you become a pathologist or a pediatrician or a geneticist, pedigree is not useful in real life much. Fine. Let's go to amyloid. There are lists of amyloid here. There are lists of diseases here. You're going to tell me the disease. I'm not going to tell at all, right? Gaurav, Dhruv, everyone who's online, Subhajit, tell. Where do you see AL amyloidosis? Comment. Where do you see AL amyloidosis? AL amyloid? AL is amyloid light chain amyloidosis, right? Seen in myeloma. AA is chronic inflammation related amyloidosis, right? A stands for serum A protein, which is actually an acute phase reactant. So where do you see AA amyloidosis? It's primary in multiple myeloma, the AL, right? And here you see secondary, it is seen in any chronic inflammatory state, like your TB, rheumatoid arthritis, any chronic inflammatory state, you see them, right? Classical. Got it? A beta 2M, beta 2 microglobulin, seen in patient with chronic hemodialysis. Okay? Classical. TTR, transthyretin, I can see them in senile systemic amyloidosis or familial amyloidotic polyneuropathies. In both, you have ATTR deposits. ACAL for calcitonin, seen in medullary carcinoma thyroid. It's localized amyloidosis, right? A beta is A beta 42 or A beta 40. Very classical for brain, Alzheimer's disease. Okay. IAPP is islet amyloid polypeptide. That is IAPP. Seen in pancreas. Again, localized amyloidosis, right? It is seen in diabetes, type 1 or type 2. Generally, what we say is, whatever comes to mind, the rarest thing comes to mind. We always say, type 1 is difficult, so let's try type 1. No. Amyloid is an extra deposit. In type 2, you have peripheral insulin resistance. So insulin gets overproduced. And I give sulfonylureas, increases insulin production. More insulin is produced, more byproduct, C protein, C peptide is produced. That gets deposited here, right? So it's classically seen in type 2 diabetes mellitus, not type 1, and also seen in insulinoma. If I have a tumor, obviously I'm going to have more of them, right? Classical for type 2, not type 1 diabetes mellitus. Please remember it's type 2 because amyloid is an excess deposit. Type 1 is insulin dependent, no insulin at all, no protein at all, no amyloid. Type 2 is insulin excess, insulin resistance, that has amyloidosis. Fine, perfect. Now let's go to pedigree. The first rule of pedigree, never forget. Any pedigree given to you, rule out mitochondrial. How will you rule out mitochondrial? You know that rule, right? Mom has 100% risk. Dad has 0% risk. That's amyloid. So that's your mitochondrial inheritance. Once you remember that, first any pedigree, rule them out. Then I have two flowcharts. These are two flowcharts, that's all. So after ruling out mitochondrial, see if all the generations are affected. Answer is no, it is recessive. Recessive, only two recessive. Only men or both genders. If it's both genders, it is autosomal recessive. Only men, X-linked recessive, that's all. It will take 5 seconds for you to solve a pedigree. Rule out mitochondrial, very, very important. See if all generations are affected. Answer is no, it's recessive. Only men, both men and women. You know what to do, right? Dominant has extra one step, that's all. All generation affected. Answer is yes. No skipping of generation. It's dominant inheritance. Then I ask a question. Is dad to son transmission present? Let's assume I have a son. I have to give Y chromosome to form a son, right? If I give X chromosome, mother can contribute only X, it becomes a daughter. So if I have an X-linked dominant inheritance, can I ever transfer it to my son? No, because I give only Y chromosome to my son, right? So if the dad to son inheritance is not present, I call it an think of an X-linked dominant. But if it is present, it is not X-linked. I am giving a disease to my son, it cannot be linked with X chromosome, it has to be linked with other 22 chromosomes only. Because to form a son, I have to give Y chromosome and not my X chromosome, right? Next, if it's an X-linked dominance, if I suspect, I ask one more question. Are all the daughters of the dad affected? Same scenario. I have an X-linked dominant disease. I am giving birth to a girl child. Zygote is XX. So which chromosome I should give? X chromosome. So I have only one X chromosome and that is mutated, and every time I give birth to a girl child, it will go to the girl child. The mutated will go to the girl child. So if all the daughters are affected, answer is X-linked dominant. If it's no, autosomal dominant. Clear? These are two flowcharts. Very simple flowcharts. These are not my flowcharts. These are Gregor Mendel's flowcharts. Father of modern genetics. He will not go wrong. Why to read Robbins? We'll go to the source and read the best way possible, right? I'm going to show you pedigrees. I want you to identify them using the flowcharts. Okay? Might be the most difficult. All generation affected or not? Yes, 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 yes. If it's yes, I'm thinking of a dominant inheritance. If it's dominant, what's the next question? We'll go back. We ask whether there's a dad to son transmission. Let's look into it. Dad is there, no son. Dad is there, no son. The answer is no dad to son transmission. If it's no, let's go back to the flowchart only. I think of, I don't confirm, I think of X-linked dominant, right? Again, I think of X-linked dominant. The next question, what should I ask is, if the dad is affected, are all the daughters being affected? Can we see? Dad is affected. Are all daughters affected or not? No. No. All the daughters are not affected. So what's the answer? It goes back to autosomal dominant. Like I said, this is the most difficult pedigree you can ever get. It goes back to autosomal dominant. My answer is autosomal dominant. Is that clear? Yes? Perfect. So it is just the flowchart. That's all. Look at this. Very simple. It'll take 5 seconds. If you want, keep a timer. All generation affected or not? No. Dominant or recessive? Recessive. Only men or both men and women? Both men and women. It is autosomal recessive. That's all, no? Simple. First generation not affected. Don't please ignore that. Right? It's very important to look at the first one. Okay? Perfect? Now, one more. All generation affected or not? No. The first generation again is not affected, right? So the first generation is not affected, it's all generation not affected. So you think of an recessive. Only men or both men and women? Only men. If it's only men, what do you think of? X-linked recessive, that's all. All are not affected and only men is X-linked recessive, right? Okay. The next is for you guys. I want you to solve this pedigree. Tell what's the answer. 5 seconds, I'll keep quiet. Same rules. Tell me what's the answer. Good. Good. Never ever forget the rule number 1. Rule number 1 is to rule out mitochondrial. Why it is very important is, if I miss that, I will say, all generation not affected, it is recessive. Both men and women affected, it is autosomal recessive. I'll make a mistake. So why it is required? Mitochondrial is non-Mendelian inheritance. So Gregor Mendel didn't know that. It was discovered after that. So always first rule out mitochondrial. The two flowcharts are for Mendel's pattern of inheritance only. Okay. Mom affected, all 100%. Mom affected, all 100%. Dad affected, 0%. It's mitochondrial. It's classical mental inheritance, mitochondrial. Any flowchart given, first see, can it be mitochondrial or not? Can it be mitochondrial or not? Can it be mitochondrial or not? Answer is no. Then go to the flowcharts. You'll be able to solve any pedigree which comes in exam. Fine. Done. Perfect. Now, I have few rapid fire questions. I want you guys to tell me the answer because these are few very classical keywords which can come in an exam and which I want you to write the right answer for these. One by one. Smoker, male, bilateral salivary gland lesion, diagnosis. If it's wrong, right, doesn't matter. Some 10-15 of them, possibly you might have one of them in the exam. Smoker, male, bilateral salivary gland lesion. One more clue, it's a cystic lesion. That's a classical finding for Warthin's tumor. Okay. Admitted patients, bleeding from the IV line. What's the diagnosis? The patient is admitted, the patient is having bleeding from the IV line. Bleeding from puncture sites is a classical diagnosis of DIC. Elderly person, massive spleen, leukocytosis. Elderly person, massive spleen, pancytopenia. What's for leukocytosis? That's your garden party or your college girl CML. I told this pancytopenia, I think of an hairy cell leukemia. Very, very classical finding, right? Right? Perfect. Through von Willebrand disease, I will think of a menorrhagia as a presenting symptom, right? That's generally the presenting symptom for von Willebrand. Admitted patient, IV line, I'll think of a DIC by default, okay? 2-year-old, prominent frontal bone, failure to thrive, microcytic anemia. I don't want the diagnosis of thalassemia, right? Thalassemia, school kids can tell. It has to be a thalassemia major because 2-year-old. I'm having changes in the bone, right? Failure to thrive, kid is not growing, has to be a thal major by default. Fine. 25-year-old, pain in the digits and priapism. What will be a diagnosis? I told one disease might not present with anemia, might present more with vaso-occlusive crisis. That's a classical finding for sickle cell anemia. Okay, sickle cell anemia classically presents like this, right? Perfect. Next. Elderly patient, metallic heart valve. What's a smear finding? What will be a smear finding? Elderly patient, metallic heart valve. You have a classical finding on schistiocytes or fragmented RBC. There's a classical finding here for schistiocytes or fragmented RBC. Metallic heart valve process will definitely cause that, right? Early morning first hematuria, rest everything is normal, pancytopenia. Classical for PNH. First early morning alone hematuric, rest everything is normal, and smear shows pancytopenia, definitely PNH. And pancytopenia plus cellular bone marrow, again definitely PNH. Okay. Gum hyperplasia or gum hypertrophy with blast in the smear. I think of an M4, M5 chloroma. Can be M2 also, but predominantly I think of an M4, M5 only. Okay. 6-year-old leukemia, ALL, 6-year-old lymphoma, Burkitt's. Because like I said, these are the only childhood lesions of hematological neoplasms what you will see. The rest are rare. Child ALL, child lymphoma, Burkitt's by default. Okay. Tell me what's his answer. I'm sure you know this. Child lytic lesions in the skull. Microscopy shows eosinophils and coffee bean nuclei. What could be the diagnosis? It's a classical finding of Langerhans cell histiocytosis. It will present mostly with a non-suppurative otitis externa, classical for Langerhans cell histiocytosis. Same lytic lesion, if it goes to an elderly, okay, I have two possibilities. Could be a myeloma, could be a metastasis. Both are possibilities, right? Child lytic lesion in the skull, I think of LCH, Langerhans cell. Elderly, either a myeloma or a metastasis. Fine. Elderly, splenomegaly, pigmented gallstones. Diagnosis? Microscopy, you see? Spherocytes, I think of a spherocytic anemia. Most likely an hereditary spherocytosis. Fine, perfect. Last but not the least, Fuller's lesion in the kidney. Fuller's means every immunohistochemistry here is, sorry, every immunofluorescence here is positive. Full house, entire house is positive here. Diagnosis, that's classical for lupus nephritis. We end with the king lupus, right? Very classical for lupus nephritis. Fine, perfect. Okay, so thank you guys for your time. We have seen quickly what is required for us. We started with non-core pathology of lab medicine and in your stains, IHCs. We went into hematology, which is the core important for an INI-CET. We also then saw a few selective areas in systemic pathology. I hope that at least one glomerulonephritis might come in the exam. And also we saw genetics and a little bit of amyloidosis, right? And finally a rapid fire, right? All the very best. You have an exam just a couple of weeks down the road. Listen to the entire marathon. Use the PDF just the day before the exam. Just skim through. It's not that you will have 100% strike rate from any of the PDF. We hope we'll have, right? But this will help you to consolidate all the 19 subjects, and that cumulatively can help you score well. Fine. All the best, guys. I think your OBG session will be a little bit later in the evening. So, President Sir will come and definitely talk to you about it, and he'll help you understand gynecology the best way. Okay. Thank you, guys. Bye-bye.